Everyone. Yeah, good afternoon. We welcome you for this webinar, which is on the fetal medicine. And I'm Dr. Ashlesha Sankhe. I'm a MOC for the today's webinar. We would like to introduce our our guest of honor, and I would like to hand over to Dr. Bella, but ma'am, without much delay, to introduce the sir.
Uh, Thank you so much, Ashlesha, for inviting me. As the Secretary AFG and convener for this webinar, I extend a warm welcome to one and all the respected faculties, respected dignitaries present here, and all the delegates who have joined for this webinar. This is one of its kind webinar of Association of Fellow Gynecologists on Fetal Medicine, in which today we are going to discuss on some of the very important topics which are, we are useful in our day-to-day practice. So we have very eminent faculties here today. Dr. Manikandan, who is there from Pondicherry. Dr. Smita Dengle is there from Bhopal. Both are very well-known fetal medicine experts, and we are going to enjoy their talks. And I'll be sharing some of my views on counseling for common anomalies. And we are very, very fortunate here today that we have the blessings of seniors like Dr. Saraugi sir, who is our guest of honor, and Dr. S.N. Agarwal. Dr. S.N. Agarwal sir is going to join time. Till then, Dr. Smita, can you mute yourself, please? Yeah.
Yes, please.
So, Shilpi, can we have the CV of Dr. Saraugi sir? Though we don't need it because we all know Dr. Saraugi sir. Shilpi, the CV, please. Saraugi sir is someone who is the founder of Association of Fellow Gynecologists. And I think those not just AFGites, but every MOGS member. And not only that, all over all the gynecologists of India know about Dr. Saraugi. Is a very senior gynecologist. And before just reading the formal CV, I would like to say that the most important facet of Sir is that for every crisis, to any gynecologist anywhere in Mumbai, Sir has been there as a savior, including me. Few years back, when I needed Sir in emergency, Sir was there. And without fail, he would come from wherever he is there, whether it's day, night, and he's there to help you and the patient. So, Sir, that is something which is a very unique quality, which is very rarely seen these days. Officially to introduce Sir, Sir is Emeritus Professor at GS Medical College and KM Hospital, Mumbai, ex-honorary in HOD R.N. Cooper Hospital, Senior Consultant at Max Nanavati Hospital, Mumbai, Director, Saraugi Group of Hospitals, Patron and Founder Member of AFG, Zonal Vice President of SOVC, and undergraduate and PG teacher, as well as examiner all over India since last 4 decades. Sir has been...
You should bother about it.
teaching since years and still is teaching and helping everyone. So, sir, I think sir has delivered n number of talks all over India and at various national international conferences, written so many chapters, books, and conducted 25 live surgical workshops all over India. That's a huge task. Right. So I think we all must give a big hand to sir. And I'm very, very fortunate here that we have Dr. Saraugi sir to bless us and to begin this webinar with. Over to you, sir.
Thank you. Thank you, Bella, for those kind words. Good evening, my senior and junior colleagues. If seniors are around, definitely good evening to them also. Special thanks to Dr. Bella Bhatt for today's convener and shortly who is becoming Vice President of Foxy. Thanks to my entire AFG team, including Dr. Nitin Shah, who has been a dynamic president of AFG. See, the beauty of today's talk is it's on fetal medicine. And who else can be a better person for fetal medicine than Bela, who has done so much work on fetal medicine that I can't even imagine. I still remember when we passed out MD, that time sonography had not yet come to the corporation hospital. We saw a packed box when I was leaving corporation in 1977. That time I had seen a packed box of sonography machine. So I think it's a good opportunity to learn certain things on fetal medicine. We have good speakers like Bela, Manikaram and Smita who will talk on different aspects of role of sonography in finding out various factors about fetus. Then we'll have a reverse panel on aneuploidy screening by whose convener is Bela, and we have expert panelists for that. With these words, all the best to you, Bela. Please start with the program. Thank you.
Thank you. I think thank you so much, sir, for your very kind wishes and kind words and your blessings. To begin with your blessings is always a pleasure. So thank you, sir. And if Dr. S.N. Agrawal sir has not joined, we would like to take
Yeah,
some
sir
of.
is not joined as yet, ma'am.
We'll
So
take few words from our president, Dr. Nitin Shah, who has joined here. And it was first, I told Dr. Nitin Shah some 3 months back that I want to do one good fetal medicine webinar of AFG. And he was immediately like, yes, whatever you want to do, good work. I'm there with you. And thank you so much, Dr. Nitin Shah, for giving this opportunity. And we would like to have a few words from you.
Thank you, Team AFG, being Bela as a secretary and Jayanti Kamath as a treasurer. I think as a team, AFG is rocking this year, and we are having fantastic program. And today also, it's one of the unique program I would like to say, where audience is going to be benefited a lot from this webinar. So without wasting much time, I can see S.N. Agrawal sir has also joined.
Okay.
So, madam, you can invite him and take his few words, and we should go ahead with the program. Thank you very much. I think S.N. Agrawal sir is there. Bela madam, you can invite him.
Yes. Sir, we are very pleased to invite you as the chief guest for this webinar. Dr. S.N. Agarwal, sir. Again, sir doesn't need any introduction. He's a very eminent senior gynecologist and having practiced for more than 50
I think it is more than enough.
Sir, sir, the one who is a recipient of Lifetime Achievement Award, I don't think I need to say anything because everybody know you have done a huge work and because of which you have been awarded with this Lifetime Achievement Award. And you are already on very prominent posts for on so many associations like AFG, IMA, AMC, MOGS, and whatnot. So, sir, yes, we are waiting to have your pulse of wisdom.
Thank you very much. The fetus is nowadays not a fetus; it is a patient, and we have to take care of the patient also. So before delivery, previously we used to think there is no role of the obstetrician to deliver the healthy baby. A live baby is more than enough. But nowadays, defect-free and healthy baby is essential, and for which we require the sonologist or fetal expert to examine them. So it is a duty of the obstetrician to refer to them for the detailed study of the fetal anomaly and direct them to the patient. Thank you very much. I wish all the success of this webinar. Thank you very much.
Thank you so much, Dr. S.N. Agarwal, sir, for your very kind words and wishes. Ashlesha, can we?
yes, madam. I was just waiting for the other panelists to be added because, or we can go ahead with your talk, madam, because I still don't know who has
Yes. We have to invite all the chairpersons.
chairpersons. Yeah. So
I can see Dr. Manikandan there. Welcome, sir. Welcome.
okay.
Thanks for
Thank you
being
very
here.
much, madam.
Yeah, I would like to introduce our chairperson for the first session, which is Dr. Bela Bhatts ma'am on the counseling for the common counseling for the common anomalies. And Dr. Manohar Motwani, sir, I would request sir to introduce ma'am as a first speaker.
Ashlesha, please introduce Dr. Manohar Motwani, sir, first.
Dr. Manohar Motwani, I don't think sir needs any introduction, but he is our past president of AFG and really a dynamic physician, dynamic speaker, is impromptu, everything with sir. Yeah. So I would like sir to introduce Dr. Belavat ma'am, and we can go ahead with the talk.
Yeah, thanks, Ashlesha. It's such a pleasure to be here in this afternoon. AFG is running at what pace? It's very difficult for oldies like us to really think. Nitin is on a roll, as I just mentioned in the WhatsApp today. Anyway, friends, welcome to this academic session of the webinar. And none other than, of course, Bela, who's organized this. And I mean, she can organize webinars like this. Over the years and years, she's a veteran at organizing webinars. Now, coming to this introduction of this small, diminutive figure with a huge impact around. I know Dr. Bela very closely, and she's among the very well respected, known fetal medicine specialists in the country. In fact, she's known far and wide the amount of information she spread through her webinars and seminars. She's a lead consultant at her own hospital, Dr. Bela's Women's Health Hospital and Fetal Medicine Center, and also affiliated to Babasaheb Ambedkar Railway Hospital, both of them being located in Mumbai. Now, how has she made this ascent? Well, she all started by being a UK certified sonologist for fetal medicine, for fetal anomalies and nuchal scans. After that, she has written a book known as A Vital Skill, that is ultrasound and OBGYN. And if you look at a career graph, in the last 10 years, she has literally been uncontrolled. She's on a ball, as I told you, even like Nitin, she's been on a roll for the last 10 years in Foxy. And she has reached heights with very few reach, but many envy. Look at the amount of work she's put in the last 10 years, where you have webinars, seminars across the country. And her most impactful 10 years of among that, I think, were the 3 years when she was the imaging committee chairperson for Foxy. And I still very vividly remember almost every week or two, we had a webinar across covering fetal medicine. That's how this topic has become such an important topic in nowadays seminars and webinars across the country. Now, as a result of all this, awards had to follow. Now, we look at this entire track record, the awards followed her where she went. And she's almost got about 11, 12, many more to come, or she must be having many more by the time this her CV was updated. She has received the CS Dawn reward. Foxy has talent. Now, this Foxy has talent is an extracurricular part of Foxy. She's an excellent dancer, and she's won this at 2 occasions with Foxy conferences across the country. Wonder Foxian, Foxy Superstar, Foxy Dhira Award, Foxy Badlav Achiever, Foxy Unifev Appreciation Award, Foxy ICOG Award, and of course, for chairing those 3 years of excellent 3 years for Foxy, got an award for Foxy Imaging Committee Award. And of course, as I said, many more to follow, Bella. There's just roses on the way now. Presently, she's standing for the post. Of course, she's our secretary of our AFG. That's the prime thing which she's at, and extremely busy. Running with AFG with Nitin is not a joke, mind you. This fellow, as I said, is just running, and this girl has to follow him everywhere this thing goes on. Presently, friends, she's standing for the post of a vice president, Foxy, West Zone. I think she's highly deserving for this. And even those people who have joined this webinar today, who are on the fence, to vote for her or not to vote for her, perhaps by the time this educative session comes to an end, definitely the balance will tilt in her favor. So, ladies and gentlemen, it's a pleasure to ask Dr. Bela to come with a talk on counseling in common anomalies. And we wish her a very best for her endeavor at making a crack at the Foxy vice president. Thank you very much, ladies and gentlemen. Over to Bela.
Thank you so very much, Manohar Motwani sir. I know you have always been very, very generous in appreciating and giving compliments. And thank you so much. Those words coming from you mean really a lot to me. Your kind wishes mean a lot to me. So thank you so much. And you have always, I have worked under your guidance in your presidency as in AFG also, and I have always enjoyed working under your guidance. Thank you so much. for being my well-wisher always and supporter. Thank you so much. Let me tell you that the session being chaired by Dr. Manohar Motwani, Dr. Urmila Sureka Madam, and Dr. Rajkumar Shah is indeed an honor and pleasure. All of three who are the past presidents of AFG and those who have always supported me in growing and reaching where I am today. So thank you so much for being there. I'll just start sharing my. I have to send request, Shilpi. I can't share this thing. It is showing send request. Shilpi, are you there?
Yes, ma'am. मैं अपना बंद कर रही हूँ मैम.
हाँ, please. Yeah. Okay. Okay. I think.
अभी कीजिए.
Yes, I should be able to now. Should be able to. But this is. Let me see. Okay. I full screen. Just couple of seconds. Hopefully it is open the same one and not the previous one. Don't know why this laptop is giving little trouble here. Let me see if this is the same. No, this is another PPT which I'll have to close. Give me a second. I'll just go out and come back as I told you. Give me a second. Shilpi, I'll
Yes,
just
ma'am.
come back. I'll just leave and come back.
Sure, ma'am.
Leave and come back. Meanwhile, Dr. Ashlesha, can you introduce the two chairpersons, please? I'll just come back.
Introduce our second chairperson for this session, Dr. Urmila Surekha ma'am, and even she is also a past president during COVID time. And ma'am's the tenure was so good, even with the COVID thing. She was so many webinars and everything was conducted in her tenure. She is a very well-known practitioner in the suburb of Mumbai, and I would like to call ma'am on this platform to chair this session, Dr. Urmila Surekha ma'am. And our third chairperson for this session is Dr. Rajkumar sir. Again, he's our past president of last year, 2024, and his tenure was really dynamic in 2024. And I have learned so many things from under sir's guidance to conduct all these webinars, and there were so many opportunities were given to me. I welcome Dr. Rajkumar sir for this session, to chair this session. Thank you so much, everyone, for coming on this platform and chairing the session.
Thank you, Ashlesha, for your introduction. Thanks a lot.
Yeah, I'll now try and share. I think I should be able to share now. Yeah, this is the correct one. Can you see my screen now?
Yes,
Yeah.
ma'am.
Ma'am, we can see.
Sorry for the technical glitch. So now without much delay, we'll start with the academics for which everybody is waiting. So I'm going to talk about today counseling for common anomalies. Well, first of all, we all know that counseling is nothing but, see, the minute we want to explain something to the patient, we know there are so many scientific terms, etc. Suppose a patient comes with, if you are not doing an ultrasound on your own, you are sending the patient out, and the patient comes with anomaly scan report, and there is something written in that, some anomaly of some system, and the patient will ask you question, now, ma'am, what next? Right? Now, there are so many scientific terms in that the patient is not able to understand. Not only that, we have to go in detail about which we are going to talk about. So it's nothing but art of transforming correct scientific information into simple language so that it is understandable by the patient. Now, whenever any patient goes for any anomaly scan, whenever a patient comes to me for any anomaly scan, they walk in the chamber with a precondition in mind that all is well. They come with a feeling that, I'm just going to have a look at the baby and the face and the different parts of the baby, and my baby is going to be normal. No parents come with the think that, there'll be some defect in my baby. They always want a healthy baby, and that's a normal human nature. But we know that we are doing a responsible job. Our words matter, and therefore we have to choose them carefully. So what I typically tell everyone is, before starting an anomaly scan, is that let us have a look at the structure of the fetus and discuss at the end. Hello, Shilpi, can you mute others, please?
Done.
And at the end also, once we have completed the detailed anomaly, second trimester anomaly scan, if we feel that everything looks okay also, we don't say that baby is normal. We have to tell the patient that majority of the anomalies we can rule out, but not all anomalies, and 100% is always at birth. Why so? There is a reference. Even the ECOG guidelines, which internationally everyone is following, tells that the 20 planes plus 2 sweeps, which is advised by the ECOG for anomaly scan, can pick up 50 abnormal fetal appearances. It doesn't tell 90%, 95%, 80%. No, it uses the word, this can pick up 50 abnormal fetal appearances. What does it mean? That means we are not ruling out for sure all anomalies, because there are standard pains in which we cannot have a look at everything. So having that general idea about counseling, well, I'm going to start with a series of cases, because each case will teach us something as to how to counsel the patient. Starting with some common anomalies like congenital talipes equinovarus. This was a case where there was isolated congenital talipes equinovarus of one side, one leg. Now, whenever there's CTEV, we know that it can be part of some genetic condition. So as far as when I use the word isolated, it means that I have looked at the fetus in detail. I have ruled out all other structure anomalies. I have ruled out any other markers for aneuploidy. And then when I find that this is the only anomaly, then we call it isolated. And it stands true for any isolated anomaly. However, in true sense, an isolated anomaly is isolated only once we have also done a genetic test and we have ruled out chromosomal problems. However, to begin with, if there is no other anomaly, structure anomaly in the fetus, no other marker of aneuploid which is seen in the fetus, then we can say it's isolated anomaly. And any anomaly, it's a rule that there can be some chromosomal or a genetic cause. So we always advise the patient amniocentesis followed by genetic test. Now, which test? Again, it's a discussion in detail, but either microarray, fish karyotype, or what the further genetic test, that depends upon the case and discussion. So in case of CTEV, isolated CTEV, once we counsel the patient that amniocentesis has to be done and we do it and rule out, then what is important is antenatal orthopedic opinion, because depending upon the degree of CTEV, they will need different treatment. So in this particular case, the patient, the amniocentesis was done, which was did not show any anomaly, and the patient continued with the pregnancy, delivered with me, and this is look at the baby at 1.5 years. The ortho opinion was taken and the physiotherapy and shoes after birth, and the baby's CTV is completely corrected. So that's how positively we have to counsel in case of isolated CTV. Now, another case, consanguineous marriage primigravida, where there was bilateral CTV, as you can see in the clip, as well as both the legs, you can see the CTV, but there were additional findings also. There was mild pilectasis, and whenever we find there are some markers, obviously the counseling goes in favor of amniocentesis followed by microarray and DNA storage. So in this particular case, the microarray fortunately did not show any abnormality, but then it is our duty to rule out chromosomal cause. And in general, if we have ruled out the genetic cause and if it is isolated CTEV, then the prognosis is good. Antenatal consultation with orthopedic surgeon will help the patient take decision, and with the help of shoes or in severe cases surgery, they'll be able to walk which the orthopedic surgeon would counsel to them with the examples of patients that they have treated. So antenatal consultation with the specialist is always better for patients to understand about the postnatal outcome. Now, this is second grade of first female 2 years, spontaneous conception, non-consanguineous marriage. Now, as you can see, there was unossified nasal bone, and in the heart, you can see echogenic intracardiac focus. There is also facial dysmorphism that you can see. Not only that, the fetal growth is at third centile. So at anomaly scan, when you have early onset fetal growth restriction with markers, we know very high chances of genetic cause. In this case, also amniocentesis was done, and it did show trisomy 21. This was a case of Down syndrome. So we counsel to rule out this and act upon them and try and find out the cause. Now, why is it important to find out the cause? Because we know that sometimes if it is just trisomy 21, 18, 13, we know the chance of recurrence would be 1%. But if it is a part of some genetic syndrome, which we'll come to know either through microarray or whole exome sequencing, then it can be autosomal recessive, autosomal dominant condition, in which case the chances of recurrence in next pregnancy would be 25 to 50%. So why do we insist on doing amniocentesis and genetic study is to help patient to counsel about the next pregnancy, because if they want to plan the next pregnancy, they should do this genetic workup now so that we can help in next pregnancy. Now, this was primigravida, spontaneous conception, non-consanguineous marriage. Now, this is interesting case. This patient was referred to me at 26 weeks. Her scan done at 18 weeks by a trained sonologist was normal. That means did not show any abnormality, but at 26 weeks, it did show double bubble. Now, the patient was counseled that this could be a sign of trisomy 21, some chromosomal problem. Patient agreed, amniocentesis done, and again, this turned out to be trisomy 21. Now, here, why I have kept this patient case here is counseling becomes very important, because the first question that the patient is going to ask you is, did the previous radiologist make some mistake? Why was it not picked up at 18 weeks? This anomaly was always there. Here we need to tell that this is one of the evolving anomaly, that the duodenal atresia was present, but the fluid to collect in the pouch and to appear takes time, which may be visible after 24 weeks. So in this particular case, the image was very clear at 18 weeks, showing normal stomach bubble, and now at 26 weeks, there is double bubble. So obviously, the sonologist did the best job, but this is evolving anomaly, may not be able to pick up at 18 weeks, and therefore we have picked it up now, and then with the help of medical board, if they do not want to continue, they may terminate, and that's what actually happened in this case. So what is important is not to say anything wrong about the sonologists, because we know that there are many evolving anomalies. Even when we do the second trimester anomalies scan, we say that this is just 19 weeks, 20 weeks, 21 weeks. The fetus is still growing. There's so many CNS, GIT, GUT. There are many cardiac anomalies which may turn up later on, and therefore these are evolving anomalies which we are not able to pick up now. So every case is a learning lesson. Now, this particular case had 38 years old primigravida non-consanguineous marriage, conceived with IVF, donor egg. First trimester screening was low risk, that means a nuchal scan plus double marker. Now here, the obstetrician was anxious. This is little old case, some 4-5 years back, where the patient was referred to me at 17 weeks for early anomaly scan. That early anomaly scan, it looked almost okay, no structure anomaly, no markers. Ventricles, brain looked normal. But because I had seen the patient at 17 weeks, I called the patient again at 22 weeks, which we usually do because we know so many structures develop by then. In which 22 weeks, I found that one of the ventricle was measuring 10.4 millimeters. That means it was mild ventriculomegaly. But the other side ventricle, if you see, right ventricle was normal, 3.6. This was unilateral mild ventriculomegaly, and so the extended scan of the brain was done in the sagittal and coronal section, which did not show any structural anomaly at that particular point in time. There was no other extracranial anomaly. So it was isolated mild ventriculomegaly. Patient was counseled that we need to rule out the genetic cause. So amniocentesis is followed by microarray, DNA storage, and torch PCR, because sometimes this is early sign of some of the torch infection. Now, we always explain to the patient, but we also have to respect the patient's wish. Now, this was extremely poor patient, had got IVF done with great difficulty. They said, Madam, whatever it is, even if there is some abnormality, genetic cause, we are okay with it. We do not want to investigate. We are fine. We want to continue, just monitor on ultrasound. And I respected the wish. There was isolated mild ventriculomegaly, which continued till 28 weeks, 2 days. And then the patient was from periphery. Patient wanted to go to village, delivered at term by LSS, a healthy male. But the story doesn't end here, because we want to know the outcome. How was the neurological outcome? So at 8 months, the patient sends this photo with this report of neurosonogram telling that the baby is normal with normal neurodevelopment, and the neurosonogram also is normal. Now, when searching the literature, many of the articles tell that when there is isolated mild ventriculomegaly, whether it's unilateral, bilateral, usually after ruling out causes, mind well, we have to do amniocentesis, rule out genetic cause, rule out torch infection. Once this is ruled out, we have to follow up these cases, because this could be beginning of some structural brain anomaly. So we have to do serial scans till term to see if there is any brain anomaly which is coming out. But if nothing comes up and your amniocentesis, genetic testing, torch PCR was normal, then the outcome is usually good. And in this particular case, patient didn't do it, but was fortunate that the baby was not affected. So the lesson that we learn here is God is God and we are not. Yes, we are here to help the patient with the help of ultrasound, genetic test, but ultimately with respect to the wish of patient. Okay. Now, as far as cardiac cases are concerned, it's very, very important, number one, that the cardiac scan and the diagnosis should have been done by an expert, because while learning, there can be a lot of fallacies. It is a higher learning curve for cardiac anomalies. Now, for any cardiac anomaly, it's very, very important that we know about the natural history of that particular condition and available treatment. 10 years back, we didn't have many centers that were offering many surgical treatment for cardiac anomalies, but these days we know all over India, we have centers where many of the congenital heart disease surgery, some good surgeons are available with good results depending upon the prognostic factors. So then we must know which are the good prognostic factors. So we know this is a very good article which tells us that the adult survival after correction in cases of VSD, PDA, ASPS, TAPVC, these are various conditions. I'm not going to details of it, is good, more than 95%, whereas tetralogy of Fallot, TGA, coarctation of aorta, VSD has 70 to 80% good outcome. But if there is single ventricle, complex CHD, HLHS, then the prognosis is going to be poorer. Also, if we look at on ultrasound, the 4-chamber size and function is normal, the outcome is good. Outflow tracks, there is no atresia of either aorta or pulmonary artery, then the outcome is good. Out of the aorta and pulmonary, if the pulmonary is smaller, outcome is better. Duct dependent, if it is not duct dependent, not progressive lesion when we follow up, or there are no extra cardiac anomalies, that means the chance of genetic cause is less, then the outcome is good. So, and in case of muscular VSD, in case of ventricular septum, we have membranous part and the muscular part. If it's isolated muscular VSD less than 3 millimeters, usually it closes spontaneously till term or in the first year. So the prognosis is good. So let's quickly have a look at these 3 cases. This is a very bad, you can see there is tetralogy of Fallot, where there's a aorta which is sharing blood from both the ventricles, but cardiomegaly, pulmonary stenosis, which is major determinant for postnatal surgical outcome, reversal of flow inductal arch. So prognosis is poor. Hypoplastic left heart syndrome. You can very well see one side of the heart is not developed. There is no flow across mitral valve and only flow across tricuspid. So univentricular condition. Again, the postnatal surgical outcomes are poor in such cases. And this was a case of isolated muscular VSD, which was smaller than 3 millimeter, after which the patient continued, followed in the postnatal follow-up. The VSD closed on its own. Baby is doing well now. So what is very, very important that suppose you are doing an anomaly scan on your own, and if you feel that there's something wrong in the heart, it's better to send it first of all to an expert for the proper diagnosis. Once the diagnosis is put, consult a pediatric cardiologist, because pediatric cardiologist will be able to tell you how is the prognosis of this after surgery postnatally, and that will help patient make decision and then let patient take the decision. Of course, any cardiac anomaly, we also have to rule out the genetic cause. So goes without saying that amniocentesis and ruling out genetic cause is extremely important. And then where to deliver is also a very, very important, because if there is cardiac anomaly, the patient has to be delivered at a tertiary center where neonatology is there, cardiac surgeon is available, where the fetus can be taken care of on birth. But if we are not sure of diagnosis, if you just tell patient that I feel there's something wrong with the heart, I'm sure the patient would go somewhere and terminate the patient. What is very, very important is, in case of cardiac anomaly, diagnosis by an expert, and then a multidisciplinary counseling by the obstetrician, by the expert sonologist, by the geneticist, and the pediatric cardiologist, and then let the patient and family take decision, because they also have to decide about the center, cost, postnatal outcome, and many, many factors. But our first aim should be first do no harm. Just because we are learning and your settings are not good and there's a lot of bleeding and you feel that there is some cardiac anomaly, and if you tell, then patient may terminate, and we may terminate a normal fetus. So first is primum non nocere. Now, this was an interesting case where there was non-consanguineous marriage, but there was a history of affected child on maternal side, some neuromuscular disorder. This patient had bad obstetric history. The first male full-term delivery died in 15 minutes. Second female died after 4 days. Suspected having arthrogryposis was the only thing written on the paper. No other papers available, no test done on either of the fetuses. And the patient was referred in third pregnancy. And on anomaly scan, this was the picture. You can see the fixed extension in the lower limb, fixed flexion in the upper limb, which was there throughout half an hour of the scan, which was done, and which was suggestive of, again, a neuromuscular disorder. So we know this is some recurrent anomaly which is going on in this particular case, where the past history is also similar. So now what was important in counseling in this patient was that in the first 2 cases, the fetus or the abortus which was terminated, no genetic testing was done. This patient was referred to me from a government hospital. So I counseled the patient that this time, even if you terminate because of this anomaly, make sure that the genetic testing of the fetus as well as both the parents is done, because then we'll be able to help you in the next pregnancy. And the patient did go to the government hospital where it was terminated. But so this was what the report, all the findings were reported, in which it was told that either amniocentesis and storage of DNA or trioxome sequencing, or after termination, the trioxome sequencing is advisable. And they did go to the government hospital, terminated the fetus with arthrogryposis, and trioxome sequencing was done, and which did show COSY-related variant, and which was homozygous in the fetus, and both parents also were heterozygous carrier for this variant. So association was found that this particular mutation, COSY-related disease, is reason for this neuromuscular disorder in all 3 pregnancies, right? So this is very important to establish a diagnosis or a genetic defect in genetic lab before next pregnancy. Now, in the 4th pregnancy, not 3rd, 4th pregnancy, patient came to me right from early pregnancy. I did a nuchal scan, which was low risk, followed by which chorion villus sampling was performed. And now this tissue was sent to genetic lab for the same COSY-related mutation, and fortunately, this particular fetus was not carrying that mutation. They continued the pregnancy and at term delivered a female of 2.5 kg. So it's very important to counsel. If the genetic testing was not done in the third pregnancy also, then we would not have been able to find out the cause. We would not have been able to help in this particular pregnancy. So that's the significance of counseling for a particular cause. Now, choroid plexus is again isolated without any other anomaly or any other marker we know, usually does good and usually resolves on its own by 28 weeks. But look at this case where there was primigravida spontaneous conception, consanguineous marriage with multiple choroid plexuses that was there, but along with that, there were so many other findings. Strawberry-shaped head, wide CSP, which was wider than longer, cerebellar hypoplasia, unossified nasal bone, micrognathia. Almost every system was affected. The cardiac anomaly, tricuspid atresia was there. Here you can see only the flow across the mitral valve, and there was tricuspid atresia, reversal of AV ductus venosus. There was also, with so many anomalies there, you know that the chances of some genetic defect is very, very high. So what is important is, number one, counsel the patient that either we do amniocentesis and do the genetic testing, because we need to find out the cause. If we don't find out the cause, we'll not be able to help in next pregnancy. So we need to find out the cause, test the parents for the same. If you do not want to do the testing now, we can do the DNA storage. That's the second option. And the third option is, if the patient doesn't want to do the procedure, antenatal procedure, and even if you terminate the pregnancy because of the multiple anomalies, patient doesn't want to continue, very, very important is to send the tissue from the abortus to the genetic lab for DNA storage, which they do for very nominal charge of 2,000 to 2,500. They store the DNA for 2 years. Now, patient may not be ready for the testing, genetic testing, which is very, very expensive at that particular time. But after 3 months, after 6 months, when they are ready for the genetic testing, then we can offer the genetic test on the same DNA. We can find out the cause and we can help the patient before they plan the next pregnancy. So this is something which is very, very important. I still see so many terminations going on with anomalies without any DNA testing, either antenatal or postnatal, or without DNA storage. At least DNA storage is something which all of us must emphasize on. If we counsel well, then I'm sure the patient is going to listen to us and at least will be ready for DNA storage. Now we have, till now, I'll quickly go through a couple of 2-3 cases. Till now we have learned about what to tell when there is an anomaly. It's also important what not to tell when there is an anomaly. Suppose there is isolated unilateral renal genesis where the other kidney is normal. There is no other marker, no other anomaly. We know that adult survival is very good with one good functioning kidney. Of course, we need to rule out other structure anomaly. The bladder is normal, liquor is normal, prognosis is good. So here, absolutely termination is not required. Another condition, isolated diastomatomyela. This patient came to me at 29 weeks, wherein 18 to 20 weeks scan was looking normal. And at 29 weeks, I could see this. You can see this fibrous band, which is there in the center, echogenic in the spine, without any associated meningocele, meningomyocele, or tethered spinal cord. And without this, usually the prognosis is good. Patient was counseled, was sent to pediatric a surgeon antenatally to find out the prognosis of isolated diastomatomylia, and patient was told that the prognosis is good by the specialist as well. So patient continued, delivered with me at term, and this is postnatal USG, which is showing diastomatomylia, which is a bony spur in the spinal cord. And after at the age of 6 years, this girl is walking well without any intervention, without any surgery. So isolated diastomatomylia without any spinal or other anomalies. Again, the prognosis is good. So we can always take help of the specialist in the counseling and counsel the patient. Similarly, cleft lip palate. We know that isolated cleft lip palate where we have ruled out this chromosomal cause. There are many NGOs which are there to help for the cleft surgeries, speech therapy, nutrition, dental, orthodontics, emotional supports. There is Mission Smile, Healing Smile Foundation, Smile Train, where in India also they do free of cost surgery for these patients and help these patients. So these patients should be motivated to continue the pregnancy and take help, because anomaly is not equal to termination. That is what is extremely important for us to understand. This is another case of mine wherein the patient came for anomaly scan directly to me. Patient's father had Treacher-Collins syndrome. Father's father also had Treacher-Collins syndrome, had some hearing problem, ear abnormality. At anomaly scan, I did find in the fetus also facial abnormalities, slanting eyeballs. There was ear abnormality, micrognathia. So I told them that there's very high likelihood that this fetus is also affected by Treacher-Collins syndrome. And would you like to do first of all the index test, genetic testing, and then amniocentesis, and try and find out whether this fetus is affected? They had not done genetic testing despite knowing that they are running in families. They refused for it. She was primary gravity patient. They said that 2 generations we are carrying this, we are fine with it. We want to continue. So we are not here to take any decisions from patients. They wanted to continue the pregnancy. They did continue. Unfortunately, at 28, 30 weeks, because of severe placental insufficiency and severe fetal growth restriction, there were bad Dopplers, abnormal Dopplers, and they did in the government hospital, did the C-section, delivered the baby, but the baby could not survive. That's unfortunate part of it. But what is important here is, even with so many anomalies, abnormalities, also the patient wanted to continue with the pregnancy, and they continued. Similarly, binder's face, again, we know it's a part of many genetic causes, skeletal dysplasia. We have to rule out genetic cause, DNA storage, whole exome sequences, etc., etc. But having ruled out them, we also know that 10 to 20% cases of binder faces will also be normal. And I had a case where there was a twins. One fetus was completely normal. The other fetus had binder's face. That's all flat, mid facial flattening. Everything else was normal. Patient didn't want any testing, continued with the pregnancy. That baby is now, I think, 3 years normal, 3 years old, and is absolutely normal, except for that facial feature. So remember, yes, we need to rule out all causes, but we are here just to help our patients, tell them about the intrauterine condition, whatever we, with the help of science, with the help of ultrasound, with the help of geneticists, with the evolving field of ultrasound and genetics, we can pick up so many structure anomalies, we can find out so many causes, but we are not here to do any directive counseling of the patient. We have to be non-directive. There are many patients even who want to continue with the Down syndrome baby, right? We know they want to continue with the fetal anomaly. No micro T, and they want to continue. Ear abnormality, they want to continue. So we are here to just tell about their fetus, which is unborn fetus, but we are all children of God, and each fetus has right to survive, and let the family and patient take the decision. And whatever words we utter should be chosen with care, for people will hear them and be influenced by them for good or ill. With this, I'll conclude my talk. And again, at the end, I'll just humbly request you to support me for the candidature for the Vice President Fox election, which is going to be held in the month of August from 1st to 10th. Online voting. Do take out your 1 minute from 1st to 10th August and do online voting, and do support me. Thank you so much for patient hearing. Thank you.
Thank you, Bella. Fantastic as always. Comprehensive, simple, easy to understand, crisp take-home messages. That's what the USP of all your talks have been. I've got a couple of questions I want to ask you. You always made a mention about isolated abnormalities. Now, there are so many isolated abnormalities. You do a very good anomaly scan, subsequently repeat your scans. But is it mandatory to suggest to them amniocentesis even if you find isolated abnormality in all cases?
Yes, sir, because the minute there is any kind of structure anomaly, the chances that the fetus will have not just common, but some kind of part of a genetic syndrome or genetic mutation we know that the genetics is evolving a lot. 5 years back, some of the genetic anomalies we were not be able to pick up. We are able to pick up with the help of microarray, with the help of whole exome sequencing. Tomorrow, patient should not ask us a question if there is a genetic cause which is found out. We do find out even after birth. There are some autism cases where actually there is a genetic cause, right? So if we should not falter on our side, counseling has to go that nowadays, because the genetics is evolving, we are able to find out the connection between an anomaly and some genetic cause which may be there, and therefore it's best. So even when we offer them, suppose microarray, sometimes it is normal, as I showed in one of the cases. I did microarray, it was normal. With that, again, we counsel the patient, we should do a DNA storage. Some patients, what happens, 20 weeks, there is nothing, but there are some CNS anomalies, some GI-GU anomalies, which may evolve at 7, 8, 9 months. That time we can again do some tests on that DNA with the help of genetic counselor, because geneticists will be able to pinpoint based on what are the findings on ultrasound that this can be part of this spectrum, and they can do some whole exome sequencing, something. Because genetics is evolving a lot, yes, it's a duty to counsel the patient.
Even for a cleft lip, cleft palate, you would like to do in case there's an
Yes.
isolation, you would suggest an amnio, correct? Now,
Yes.
how does a gynecologist, average people like me, decide whether you require a micro arrow vis-a-vis a whole genome sequencing? How will I know what to do?
So the best thing is, suppose whenever there is an anomaly, first of all, we try and find out. Best idea is, you can, if you are suspecting that when we do an ultrasound, suppose as I showed that anossified nasal bone and EIF, I know that very high chances, or double bubble, or duodenal atresia, I know very high chances of trisomy 21. So in that case, what I would offer is FISH, and then I'll take decision whether to go for karyotype or microarray. FISH is something which is within 72 hours will tell me common trisomy 21, 18, 13 is there or not. 99%, it will tell me. So if it turns out something from that, you can go for karyotype. Suppose it does not show 21, 18, 13, then the best option would be microarray, because it has extended spectrum to pick up some of the micro deletions, duplications, which a karyotype or a FISH will definitely not, but even the karyotype will not be able to pick up. But having said that, why do we say that we should always keep a geneticist in a loop? Because no test tells that 100% we can rule out all genetic abnormalities. Karyotype, microarray has a higher spectrum than karyotype. Whole exome sequence has a higher spectrum than microarray. Again, whole exome sequencing also will not rule out all genetic cause. So we can tell patient that we'll try and rule out common genetic problems. The rare ones we can still may not be able to pick up. We are just trying to help you maximum how much we can help with the help of science and genetics and geneticists and genetic counselors. But everything we cannot rule out as far as genetics is very, very complex. So yes, these days many centers directly go for microarray. They don't offer even karyotype. Microarray because it's a wider spectrum than karyotype. So directly go for microarray, and then if you don't find anything, you can do DNA storage. So in later months, if you want to do something, microarray and DNA storage is a good option.
Then what is the role of whole genome sequencing? In which cases you will say I must do whole genome sequencing?
So there are, suppose skeletal dysplasia is there. It is not a part of there is no micro deletion or duplications. I know it's a single gene disorder. So when I suspect single gene disorder, I will advise for whole exome sequencing. Not only that, any anomaly is there. Suppose you have some confusion as an obstetrician also, if you patient comes with some report and if you have some confusion before offering amniocentesis, you must always keep a geneticist in loop. They will be able to guide you whether you should go for whole exome sequencing. There is also clinical exome sequencing. They'll be able to pinpoint that you can go for this panel first, then we'll do the rest of the test, because this is not something, it's developing every day. The answer will be different after 2 months, 6 months, 1 year. Like
Coming to DNA storage now, when you say postnatal, after the abortion, the patient is terminated, what tissues you store, which are the labs in Bombay which help us to do this?
Yeah. So every genetic lab where you send your samples of amnio would do DNA storage. So Lilac, MedGenome, LifeCell, there are so many genetic labs to name. The sample taking is easy. You can take 1 centimeter square area from the shoulder, thigh, tip of finger, 1 centimeter of cord. In normals, either the sample which is given for Korean villus sampling, which is provided by the genetic lab, or if you don't have that, normal saline with few drops of antibiotic, any antibiotic, because this is for DNA storage. So we don't want contaminated sample. So normal saline with few drops of antibiotic is also good enough. But one thing is for sure, please do not put formalin because this is for DNA storage.
Yeah, that's right.
So formalin should not be put.
Anyway, thank you very much. Any other questions, guys, from the chat box? I don't know whether the chat box is showing it. Yeah, Raj, please.
In continuation of what Manohar was talking about, what would be the highest limit of weeks of gestation when you would suggest amniocentesis?
Any week of gestation, sir. Because
Any week.
any week after 16 weeks, amniocentesis. Because even if there is some anomaly that we pick up at, say, 32 weeks, there is a double bubble, right? I want to rule out whether there is a chromosomal cause. Now, suppose if it turns out to be trisomy 21, right? At labor, it's going to help in decision making. Even if we get the report after 3 weeks and patient reaches close to term, if there is fetal distress, I will not do C-section. I mean, there are a lot of implications of that report. So yes, must counsel and do amniocentesis, tell the patient that I'll be able to find out the cause and it will have bearing on labor as well. And to find out the cause, of course.
So
The
you
other
would
thing is, what is the importance of a 24-week scan, specifically for looking at the cardiac abnormalities? And which patients would you suggest that, or routinely for all?
So basically, if I have done a good nuchal scan, I would do a anomaly scan close to 19-20 weeks. These days, we have the limit of termination close to 24 weeks. So 19 to 20 weeks, a good scan. But a relook at around 23 to 24 weeks is a good, mainly for vermis of cerebellum, which is in the brain, which we sometimes some of the anomalies of the cerebellar vermis we are not able to pick up. And cardiac also, as far as some of the small, VSDs or some of the small membranous VSD or something, which we may not be able to pick up some of the valvular abnormalities, we may not be able to pick up early, Though, having said that, 19 to 20 weeks anomalies scan, we always do primary cardiac screening with four chamber, three vessel trachea view and arches, and 90% of the major cardiac anomalies we can very well see even in 90 to 20 weeks scan. Some of the aortic arch anomalies, coarctation of aorta, etc., are the ones which may come up little later. I mean, we may be able to pick up little late, 20 to 24 weeks.
Yeah, but these would be probably patients who are high risk for developing cardiac abnormalities. For example, diabetics, for example, patients of SLE. But would you routinely advise patients who have gone through a normal anomaly scan at 19-20 weeks
No,
to go
we
in for
have,
a cardiac
we have
evaluation?
ruled out. No, not irregularly. Yes, but the only thing is, as I said, for brain, I will always try and have a relook at around 23 to 24 weeks for sure. Yes.
Bela, I have a question. Unilateral choroid plexus cyst and echogenic focus in the heart is a very common abnormality which we find. Will we do amniocentesis for these patients? Because usually they resolve and we are sure that we have not found any other abnormalities.
So there is, in such cases, ideally speaking, EIF is a part of trisomy 21. Choroid plexus cyst is usually a marker of trisomy 18 if there is associated other structure anomaly.
No other abnormality.
Marker of each. So to be very precise, there is no specific indication for amniocentesis per se in this particular patient. But however, how the patient has been counseled before, how anxious the patient is also very important. So again, if you want to rule out some common problems, NIPT is also one option, and patient is very anxious at any day, amniocentesis is going to allay their anxiety. So that's how the counseling goes, depending upon how the patient also has come. Because sometimes this patient has gone to 2, 3, 4 places. They are so anxious, they want to rule out. I think Dr. Rajkumar only had shared one such case with me, wherein amniocentesis was advised. So a lot of factors are there when we are counseling the patient.
Bella, I wanted to know tomorrow if any minor abnormalities are there, you should consult a genetic specialist.
What is a minor abnormality, sir?
Now, for example, syndactyly, polydactyly.
Of course, it can be part of some syndrome. First of all, whether it has been done by a good trained sonologist is first thing. And yes, it can be part of some genetic syndrome at times. Yes. I would at least take a geneticist opinion for sure.
Anyway, thank you, Bella. 212 people on the webinar. They have no questions, so I think you've been very, very clear with your talk. Should
Thank
we
you.
go ahead? Yes, yes. MOCs can go ahead with the next talk, please.
Thank you so much. Thank you so much, beloved ma'am. I just had one question, ma'am. That most sometime we send the samples for the this thing, and report comes at the end of the 2 weeks that it was they could not see the fetal cell clearly and the contamination, and it's really very disheartening for a clinician as well as for the patient. So how are we going to take care of?
For any test, a pre-test counseling is very, very important. How important is the post-test counseling? Pre-test counseling is very important, in which we all, because of lack of time, we are not able to counsel. So culture failure, some kind of this kind of results are known. It's not zero possibility. So if you have done a good pre-test counseling, we'll be able, because these are things which are possible, then we may have to resample, etc. Though we should have taken due care first thing. I'm very happy that Dr. Manikandan is here, and I have been at his center for 15 days. And I've seen how beautifully he does the pre-test counseling, whether it's screening test, whether it's diagnostic test. He has videos ready for counseling. And I have also learned a lot from him. So yes, Dr. Manikandan, your comments on this.
Can you rephrase the question, madam, please?
She is saying that sometimes amniocentesis, we have done the amniocentesis, sample is sent to the lab, and after 2 weeks, we get the result that it was contaminated and we couldn't give the result.
All right. All right. That should be a very, very uncommon scenario, but one that we should be prepared in all cases. We quote a rate of about 1 in 2,000 for culture failure, sample contamination in amnio. In CVS, it's slightly more. It's about in 1 in 1,000, but that we would be able to tell at the time of the procedure itself if we had got or not. So we would counsel, we would take consent. So when the result unfortunately turns out to be like that, we would be honest with the patient and say we need a second sample, or in the case, sometimes we can go back to NAPT, though that should have been avoided. Rarely.
Thank you so much, sir. Thank you so much.
Yeah, I think we are all waiting for Dr. Manikandan's.
Yeah. So I would like to request Dr. Rajkumar sir to introduce our second speaker, Dr. Manikandan sir, and I will just hand over to Dr. Rajkumar sir.
So good evening, friends. It's my proud privilege to present Dr. K. Manikandan from Pondicherry. His current position is the lead consultant in fetal therapy, Fetal Clinic, Pondicherry, KMCH Coimbatore, and KM Hospital, Pune, as a visiting professor. Visiting Professor Perinatology, Pondicherry Institute of Medical Sciences. Research and special interests are specifically for preeclampsia prevention and teaching evidence-informed practice. Dr. Manikandan has had a postdoctoral fellowship from the Mediscan Systems, Chennai. He was a former associate professor of obstetrics and gynecology, JIPMER, research fellow in fetal medicine, King's College Hospital, Fetal Medicine Foundation, UK, special training under teacher training course for teachers of higher education, JIPMER, statistics and epidemiology training from Harvard, quantitative methods in clinical and public health. Dr. Manikandan is going to speak to us on the cervix. basically,
Is it a
short
short?
cervix, is it a single entity? Now, cervix happens to be an important organ for us in obstetrics. A short cervix, a long cervix, a cervix which is funneling, and all other things. So, more about it from Dr. Manikandan. So, Dr. Manikandan, please go ahead.
Thank you, Rajkumar sir, and my greetings from Pondicherry. I thank all the organizing team from AFG and the office bearers and the illustrious leaders. So thank you very much for this opportunity. I am able to share the screen now. So let me share the screen and oops. Is my screen visible? Not yet,
No.
right?
Not yet.
Okay, hold on.
Yeah.
Okay. All right. So the talk is primarily aimed at the younger lot, the obstetricians who are new and are often motivated by misreading of the published evidence and those who go by what is on the paper. So it's not to belittle evidence. I am a person very much in favor of an evidence-based practice, and I teach a lot of stuff on evidence, how to interpret and how to utilize evidence in our practice. But of late, what we have seen is it does have its limitation, and if you don't interpret it properly, it can lead to a suboptimal outcome for the patient, right? Okay, so greetings from Fetal Clinic. We are, as Madam told, a small-sized clinic in Pondicherry, but we do try and practice a high-level fetal medicine stuff. As a nation, we do not have an enviable position when it comes to preterm births. We surpass even the great neighbors, China. Our preterm load is very, very high. The thing about preterm birth is that over the years, in spite of the research and the advances that happens even in the Western developed world, preterm birth around the 32 weeks mark has been always constant. It has never come down. And we know that the NICU advances have reduced the risk of neonatal demise, the risk of neonatal morbid survival up to 32 weeks. So beyond 32 weeks, it's a good outcome in any NICU nowadays, but that risk up to 32 weeks is still significant. So the question is, why have we not prevented preterm birth yet completely? Why has it not come to our control? It's because it is not a single entity as such. Even the process, the phenomenon of preterm birth itself is complex interplay of maternal factors, uterine factors, fetal factors, sometimes infection, and still undefined and other entities have a role. And therefore, there is no single preventive intervention that is available, which was well brought out by the 2012 Global Action Report by WHO termed Born Too Soon. And this was a report on preterm birth, and it was a very massive report. It sort of gives us action plans at several different levels, most of which are not for doctors in our practice. What we can do is identify high-risk mothers. That is one level that we can do. And secondly, to do damage control, which is like when a preterm birth happens, what we do. For example, in utero transfer, steroid, magnesium sulfate, antibiotics, and NICU. So that is damage control. So we are now going to talk about identifying the high-risk mothers. And when we talk about preterm births, 1/3 is iatrogenic, where as obstetricians, we advise the mothers to get delivered in a preterm gestation, but 2/3 is spontaneous. Now, if you look at those who are having spontaneous preterm birth, only about 15% will have a history of previous preterm birth, and the remaining 85% would not have it, which means that if you go by history, then your screening for preterm birth would only identify 15% of those who are going to have a preterm birth. Over the time, biochemical parameter called fetal fibronectin has been introduced, came in favor, went out of vogue, but it adds another 25% such that if you have history and fibronectin, you would pick up 40% of them. But if you add cervical length to history, you would actually detect 50% of them who are going to have a preterm birth. So in short, of all the screening methods available, cervical length on the background of a good history taking would identify 50% of women going to have a preterm birth, and that's the best of the tools available yet. So the moment we say cervical screening, we think that, okay, my goal is to identify short cervix and then do this treatment. So the question is short cervix really a single entity as it has been portrayed in the various trials, in the various studies and papers? I beg to differ, and I have been teaching this to all my students also. Cervix is not a single entity, and we will see how it is. When we take the cervical length and we say your short cervix, we know that in the mid trimester, the cervical length is distributed normally, as you can see there, with a mean and median coinciding around 4 centimeters or 40 millimeters. Now, any normal curve, we can draw anywhere, let's say the first 10 percentile, and then say below that is abnormal, and that is what is meant by cervix length of 25 millimeters. There is no magic. Cervical length of 25 millimeters is a statistical cut point that will include 10% of the population, more by convenience rather than on any action. Less than 25%, about 80% would still reach term pregnancy, and only 20% will have preterm birth. So this we need to remember. And as the cervix becomes shorter and shorter, so below the 25 mm, the chance that she will deliver preterm keeps increasing. So there is a linear relation between that. Now, I will come back to this slide again after explaining the cervix a little bit, and then we will see why we cannot put all the short cervix into one basket. We know that the gestational length is a complex interplay of myometrial quiescence. The uterine tone keeps on at a very low baseline tone for much of the pregnancy and then slowly rises in the pre-labor period, during which time the membrane integrity is held virtually at 100% immediately after the first trimester. And throughout this period, the cervix acts as a sphincter, like any other sphincter organ in the body. It acts like a sphincter and is tightly closed. And then during labor, the myometrial activity increases tremendously. The membrane integrity ruptures, falls down to 0. That means it ruptures at the time of birth. And the cervix, from being a tightly closed os, becomes fully dilated, is no more a sphincter, allows the baby to come out, and immediately remodels back. So, interplay of myometrial quiescence, membrane integrity, and cervical support is needed for maintaining the gestation. And when the myometrial quiescence is asynchronously activated, it results in preterm labor. When the membrane integrity is asynchronously activated, it results in premature rupture of membranes, pre-labor premature rupture of membranes. And when the cervical sphincter is asynchronously activated, it results in a mid-trimester loss with a characteristic history. Prior to Dr. Shirodkar, people have attempted, and many of our teachers there would know, the cervical repair that was attempted for preterm birth, which were not at all effective because they involved something like this, cutting the cervix longitudinally and stitching up to increase the length. At that time, the understanding was the cervix was a structure composed of collagen. So if you lengthen it and stitch it up, it will give more support. Okay, and then enters our the great Shirodkar, who presented his theory and the treatment of habitual abortion or recurrent miscarriage, as we call it now, where he showed that a circumferential stitch at the level of the internal os was very effective, which led us to understand that there was something abnormal at the internal os in the radial manner, not in the longitudinal manner. And this we know through studies of histopathology of the pregnant uterus cervix and non-pregnant cervix, that there is a smooth muscle band at the level of internal os. So there is a smooth muscle band at the level of the internal os, which is the sphincter, and the rest of the cervix is composed of collagen extracellular matrix. So what happens when changes happen in the choriodecidual interface? If there is a chronic inflammation due to stretching, due to infection somewhere nearby, due to infection far away, even in the periodontal region, these inflammatory cytokines, activation of the melanoproteinases degrade the extracellular matrix in the cervix region, and tissue remodeling sets in, which gradually takes up the cervix, which gradually utilizes the collagen component of the cervix. So that ends up as a small cervix, smaller cervix, and ends up in preterm labor. Whereas if there is a deficiency in the smooth muscle sphincter complex, there becomes a mechanical weakness of the internal os complex when a critical pressure is reached within the uterus. That means in some cases you can have a opening up of the cervix at 16, 18 weeks also. In some cases at 22 weeks, 24 weeks, 26 weeks. So it happens, but the process is the same. The sphincter gives away because of the pressure, and that pressure is different in different cases. There's not much of initial tissue modeling, but the moment you start giving away, further action will happen. The tissue modeling will take place. It will also show short cervix, and it will show other features of funneling, prolapse of the membrane into the os, and then the myometrium gets activated. Then they end up in mid-trimester loss. Right. So this can be observed by ultrasound. This is a cervical image. You can see that the cervix length is short, but you can also see that up to here is the original cervix, lined by the cervical glands, which tell us up to where originally the cervix was. And you can see that the internal os is open and the membrane is funneling in. So this is a short cervix, but an open cervix. Compare this with this cervix. This is also short cervix, but the internal os is closed. There is no funneling. Once again, another case of internal os open and the membranes prolapse deep into the cervical canal. And compare this with a normal looking closed cervix. Here, the cervix has opened very much and is just held by a tiny bit of residual length, and you can see the prolapsed fetal foot inside. And this is after the cerclage. We have reclaimed a lot of cervical length, and the cervical length is restored to 1.9 centimeters. Now, with this understanding, can we say that all those in the short cervix can be considered as one entity? Of course not. It is like putting apples and oranges in the same basket. For example, this is a 27-year-old primary dentist couple in 2015. She came to us at Target Scan, and at that time, we did not have a protocol of doing a vaginal cervix, vaginal transvaginal ultrasound. So a transabdominal cervical length was measured, which in retrospect, we have corrected it. That was a mistake we shouldn't have done. In the next week, she called up and told that she has expelled the fetus en call. So we were all very worried. I told the primary obstetrician that no, this was a missed case of cervical insufficiency. Now that we have the history, in the next pregnancy, you please put a stitch at around 14 weeks, a history indicated stitch. She became pregnant the next pregnancy and she shifted to Chennai. There, they measured the cervical length and said the cervical length is all right, you don't have to worry. Although the couple insisted on cerclage. So the obstetrician there said, okay, first let's do the quadruple screening. You come back, after that we'll do. But again, she expelled within 2 days before the quad screening came back. So what it tells is the cervical insufficiency is a different disease and doesn't behave the way that can be picked up by cervical length screening. The cervical length screening is for picking up the short cervix due to chronic inflammation. So both preterm labor, PPROM, can result in cervical tissue remodeling that can ultimately cause short cervix, but in both cases, it would be a closed cervix. Cervical length can also be used in case of threatened preterm labor, where if you don't have a very short cervix, you can safely say, okay, we will wait and we will not get the trigger for giving the steroid immediately. So in summary, if there is a short cervix, it could be possibility A, it's a normal variant in the population in which there is no tissue remodeling. Possibility B, it is short because of abnormal extracellular matrix remodeling, and this is a sign of chronic choriodecidual inflammation, and this would lead to preterm birth. So this is a medical disease, and the treatment for this medical disease would be to stabilize the lysosome enzymes within the cervix by giving progesterone that would act locally in the micromilieu of the cervix. So therefore, it has to be a vaginal progesterone. And by stabilizing the lysosomal enzymes, we would be able to decrease the risk of preterm birth by half. Option possibility 3 of a short cervix is there is an abnormal internal os sphincter complex. Therefore, much of the cervix has opened and the residual cervix is looking as short cervix. Now, this is not a medical disease. This is a surgical disease, and any amount of vaginal progesterone stabilization of the lysosome is not going to replace the strength of the sphincter complex, and this would lead to late second trimester loss or preterm birth in the early third trimester. All right, so let's quickly look at risk scenarios. Women with previous spontaneous preterm birth. So how do we handle? We can think of cervical length monitoring, or in the past, before the prolonged trial came, there was some suggestion that the 17-alpha hydroxyprogesterone caproate was useful. The prolonged trial has proven that 17-OH-PC is not helpful in prolonging the pregnancies in this category. Cervical length monitoring is a good option. We start at 16 to 18 weeks. We repeat 2 weekly up to 24 weeks. The cervix is stable. Then we don't have to do anything. If the cervix is less than 25 and closed, then vaginal progesterone is indicated. Now, it's very important whenever there is a history of previous spontaneous preterm birth is there, we need to ask in detail whether that was a insufficiency event. So typically in my clinic, I sit with them and I say, when did it happen? The mother usually, because of the trauma, they will know the date and time, and then they will say, and then I will say, okay, let's start from the date before. Tell me all that happened, everything in detail. So somewhere the clue will come. They had a discharge, they had a mild, vague feeling of filling in the vagina. So they went and did something, they exerted, something will be there. So that is important. If there is a notes that says that the bulging of membrane is there and she was not with that much pain, that also will help. So history is very important. If it is by history, if it's insufficiency, there is no role for cervical length monitoring, as we had seen in the case of a dentist. All right. Now, what happens in a scenario where there is a mid-trimester cervical length of less than 25 millimeters, but it's a closed cervix. In this case, it's we can't say whether it is a normal variant or tissue remodeling that is happening. We can't take the chance. So generally, when it is less than 25 mm, we say start on vaginal micronized progesterone. You will decrease your risk of preterm birth by 50%. The dose is about 100 to 200 milligram at night, self-administered. The number needed to treat to prevent one preterm birth in this scenario is 7. That means that you are really effective. If there is a history and findings of cervical incompetence, for example, in the dentist couple, straight away a cervical cerclage is indicated. And in the case of history indicated cerclage, do the first trimester screening, first trimester anatomy, exclude major anomalies, and by 14 weeks, that's the best time to put the cerclage. The cervix will be firm enough, not very softened, so you can get a good purchase on the cervix after the cerclage. What about women with multiple pregnancy? There is no role for routine 17-hydroxyprogesterone or cervical cerclage. In fact, if you put routine cerclage, you are adding a layer of surgical trauma to an already over-distended and a sort of inflamed choriodecidual interface. So you will only be accelerating more preterm birth. Of course, multiple pregnancy following IVF, there is a higher incidence of cervical insufficiency due to various reasons, multiple times instrumentation in the cervix, increased exertion in the uterus. So we need to identify if it's a cervical insufficiency by serial monitoring. And if it is an insufficiency, we can put it. Otherwise, routine cerclage, it's better to avoid. In case in multiple pregnancy, while doing the cervical assessment, if there's a short cervix, the best option is to go for a vaginal progesterone if it's a short and closed cervix. Therefore, to conclude, screening for preterm birth is by universal cervical assessment. So all of us, we know the transvaginal probe is our extension of the digital examination. So get used to how to do a cervical assessment. And when you see a short cervix, ask yourself the question, is it a closed os or an open os? Is it a short and closed cervix or a short and open cervix? And if it is short and closed cervix, it is a medical disease. Treat it medically, stabilize the local lysosomal enzymes. And if it's a short and open cervix, then it's a surgical disease, treat it surgically. Thank you very much. That is the end of the talk.
Thank you, Dr. Manikandan. That was a very practical and a very lucid talk on the importance of a short cervix diagnosed by transvaginal sonography. Now, I have a few questions basically. There was a talk by Dr. Salim Daya in one of the conferences on recurrent pregnancy loss, and they had gone and studied the cervical length at right from the 12 weeks onwards. And his contention, of course, this is an unpublished data. This is, we had presented in the conference as such, that in patients who have recurrent losses, it is important to start assessment around 12 to 14 weeks. And by extrapolation, they had come to a conclusion that if the cervical length is less than 3.5 centimeters at 12 to 14 week scan, then a cerclage is indicated. So this is one thing which I would want to impress on. And maybe not much work has been done on this, probably more work requires to be done on this as such. The second thing is the use of vaginal progesterone. Of course, vaginal progesterone has come in a great way as such, but 17-hydroxyprogesterone, of course, as you mentioned clearly, that the trial showed that it is not as effective as it was portrayed to be as such. But more important is 17-hydroxyprogesterone has got some kind of activity on the fetus where they have studied almost 11,000 babies they have studied and found that there's an increased incidence of the childhood cancers basically. And so therefore, that is something which requires to be taken into consideration. And when you use 17-hydroxyprogesterone, of course, this was not there. We were, as students, have used it left, right, and center. But the present data that is published in the American Journal of OBGYN November 21 issue, that clearly mentions that this is something which has to be seen with caution and requires to be brought into practice as such.
Yes, sir.
And of course, you mentioned about the role of cerclage in twins as such. So I do agree with whatever you said, and fine, I think that's really good. So any more questions?
Dr. Manikandan, one thing I want to ask you is this thing which you told me about the cervical length and that we had the dental patient. I had a similar case just 2 weeks back. 19-week scan done, anomaly scan, cervical length 3.8 centimeters. And believe me, within 24 hours of the scan, she comes with herniating membranes.
Yes, sir.
I mean, she aborted within an hour of admission.
Yes, sir. Yes, sir. Sir, just to re-emphasize, the length is a screening for choriodecidual activity. It is not going to predict cervical insufficiency. The incidence of cervical insufficiency is 1%, and the lucky ones get spotted during our cervical assessment. So most of the cervical insufficiency would be by history. Very few of them would be by ultrasound. So the old teaching still holds. Cervical insufficiency, if you get the history, act on it.
But as such, now what has happened at the drop of a hat, we obstetricians put a stitch. You see 2.5 centimeters, they don't even, there's a jump. Next morning, the patient's at the table and a stitch is put. Same thing with, I think, twin pregnancies at 13 weeks. The IVF people say you have, the patient is told already that 13 weeks, ask the doctor to put a stitch.
Sir, let me comment on that, sir. The second part will be what the IVF practitioners do. The first part is we have misread the trials. The trials have put all short cervix into the same group. So if you have short cervix, I will put cerclage and I will put progesterone. Now let me compare. Now what happens if there are 100 short cervixes? 2 of them may be due to cervical insufficiency. So if I put cerclage, that too will benefit. The remaining 98, which are inflammatory cases, will get an added layer of surgical trauma and will only fare less. They will only fare worse. When I give progesterone, the 2 cases which are surgical cases, they will fail. And then we say progesterone won't help in everybody, but the remaining cases would be benefited. Since in all trials, they combined all short cervix as a single entity, and because cervical inflammation, short cervix is the majority of this, always progesterone will hold higher outcome in these studies. So the inclusion criteria is at fault.
And you give a lot of importance to funneling of the internal loss when you take the when you have to decide about incompetence. Does it make a difference? The cervical length 1.5 and there's funneling. So that puts your diagnosis more in favor of cervical insufficiency?
Absolutely, yes, sir. It's the internal loss that decides whether I'm going to do a medical treatment or a surgical treatment.
The same thing, again, the same girl around 19-20 weeks, internal loss funneling, 1.8 centimeter cervix. I tried to do a Shirokor on her. Within 15 days, she came with leaking and I had to cut the knot.
Okay.
Dr. Manikanandan, can you tell me what are the different cervical lengths at different stages of pregnancy? Because someone has done a study on that and they have come out with different lengths of the cervix in a normal pregnancy.
Yes, sir. Sir, to start with and to address Dr. Rajkumar sir's initial comment, the cervical length is unreliable before 16 weeks because before 16 weeks, the lower uterine segment, which is still not yet formed and is referred to as the isthmus, is always opposed. Therefore, we will not be able to, by ultrasound, differentiate where the internal os stops, where the cervical canal stops, and where it is isthmic contraction apposition. So because of this, even in Fetal Medicine Foundation, they do not advocate a first trimester cervical length measurement. Rather, we can do a cervical subjective assessment, and if the funneling is there, which the earliest that I have seen is at 14 weeks. Then that can be acceptable. But when it is closed, when it is always opposed, the cervical length is really not reliable. Therefore, I would not put my money on the length measured before 16 weeks. From 16 weeks onwards, the cervical length is fairly constantly distributed. There will be a variation, like a normal distribution, like I showed. And by 21, 22 weeks, the mean is about 4 millimeters. But up to 2.5, you can see and take it as normal.
Okay, I was going through Greenhill's textbook, and what they mentioned was Reynolds phenomena is responsible for incompetent toss. I don't know whether you have heard about Reynolds phenomenon.
In
I'll tell you what it is. What Greenhill mentioned in his book was there is a spherical measure growth of the uterus all the time.
yes, sir.
It comes to about 20-22 weeks. When there is a spherical growth, and if cervix is not incompetent, the growth will continue in a spherical direction properly
Yes, sir.
till 12 weeks. And beyond 12 weeks, at the internal loss, because there is a hard internal loss or strong internal loss, the axis will move upwards, and again the spherical growth will continue, and it will not cause incompetency of the cervix and abortion.
Yes, sir.
But in a case of incompetent toss, because there is incompetency at the level of internal loss, the spherical growth will not continue and the cervix will be taken up and it will result into mid-trimester abortion. He
Yes.
has clearly mentioned that that is the reason why mid-trimester abortion occurs in all cases of incompetent toss. It cannot occur without beyond mid-trimester. So I
Yes,
don't
sir.
know how far you agree with that. I don't know.
So this is the mechanical explanation, and it doesn't contradict anything that we have discussed. We are discussing that if you see internal loss open, then don't think of not putting a stitch. Put a stitch. That's what we are discussing.
Just one quick question, if I can ask Dr. Manikandan. So all short services, as you said, less than 25 millimeters, 20% will go for preterm delivery, 80% may not.
Yes.
Do you find elastography useful in this cases to differentiate it between two mechanical property? Because I've seen in couple of cases where short service, but elastography is good and they fare well.
Yeah. So the problem with elastography now is that the strain technique depends on how much you push. So that's going to be different between different operators. So it's gone. The shear wave is not yet perfected for cervix. We have a top end model, and the moment it came, it had shear wave. So I told one of my fellows, take it up. After 1 month, she gave up. She was my best fellow. And she said, sir, it is showing inconsistent in all cases. So at present, we have given up. I'm sure some when more data comes and when the technique becomes better, we'll try and include that. But it has some role, definitely.
Dr. Manikandan, I have a question. In medical management of short cervix, you mentioned natural vaginal NMPs. Do probiotics have a role?
Yeah, should have a role. At present, we don't have a robust data as much as we have for vaginal progesterone, but vaginal microbiological milieu would also be expected to alter the inflammation in the cervix. So it should have a role.
I think there is one question from Dr. Monica Agarwal, and that is, if cervix is normal, but small funneling is seen in primary gravida, should we proceed with cervical cerclage?
It's a beautiful question. Monica, thank you for that. And in fact, I wanted to show some images, but it will prolong. When we do a cervix, we should be very careful on pseudo lengthening and pseudo funneling. So if you give more pressure on the cervix, you will get pseudo lengthening. A normal short cervix would be missed. If the patient is very anxious and we didn't give too much time for her to mentally relax, we see a lot of lower uterine segment contraction, the same ischemic contraction that is universal in first trimester can be seen in up to 25% of second trimester, and it's usually transient. If you wait for some time, it will go away. But in the presence of an ischemic contraction, if there is symmetric ischemic contraction from anterior and posterior isthmus, then you will get pseudo lengthening. But if there is only one of them contracting, then you will see a pseudo funneling. So in most cases of small funneling but looks all right, then what we say is we finish the anomaly scan, we ask her to wait for some time. After 2-3 hours, we repeat. If she is the last case of the day, we ask them to come after 1 or 2 days. If it's still persistent, then we will do. In the meantime, we will do a fundal pressure and see if there is a dynamic change also. All borderline cervixes, 2.5, 2.6, 2.4, we'll give a fundal pressure and see if the internal house opens or not. And again, cervical assessment itself is a 2-minute full 2 minutes, not a go in and come out. You have to wait and see. So what we do in our clinic is go first, assess the cervix, measure, take an image, then actually study the part of the fetus which is in the lower segment. For example, with the spine, study the spine, take a few images, then do the uterine artery, then look at the lower segment, then look at the cervix once more, then finish. So by this time, 2 minutes should be over.
Thank you so much. I think Dr. Manikandan, it was a brilliant presentation and wonderful interaction at the end of it. So doubts of so many of us were cleared. And thank you so much for sharing your views and knowledge on this and for being with us. And
Thank you, madam.
I think Dr. Smita Dengle has been waiting for quite a long time. So let's welcome our third speaker because this is something which will go on and on. Please be with us, Dr. Manikandan, if you are there.
Thank you, ma'am. Thank you so much, ma'am. Now, I would like to request Dr. Rumila Surekha, ma'am, to introduce our third speaker for the session, Dr. Smita Tengre. And madam is going to talk about the screening for the preeclampsia, what's new.
I welcome Dr. Smita from Bhopal. She's a specialist in fetal medicine from her hospital, Bhopal. She has been a Fetal Medicine Foundation certified NT scan, anomaly scan, invasive procedures, and she's a FOXY, ICOG, and fetal gynec imaging certified trainer for the ultrasound courses. She has been the treasurer of Bhopal OBGYN Society, member of ICUOG, Society of Fetal Medicine. She is a member of FOXY, and her special interests are in teaching, academic training, and screening of the fetus and fetal interventions. Without wasting time, I call upon you, madam, to tell us about the screening of preeclampsia, what's new we need to learn.
Thank you very much. Thank you for the kind introduction. And it's my real privilege to be here on this webinar today. Thank you so much, Belavat ma'am, for inviting me in this webinar to be among all these stalwarts and such beautiful discussions going on, a real academic treat going on. Please allow me to share my screen.
Yes, ma'am.
So I think it is visible now.
Yes, ma'am.
Yes.
Is it visible? Yeah.
Yes.
It should be.
Yes.
So now I would be speaking about screening for preeclampsia, a very important topic, I would say, especially for our country. This is the world scenario. This map shows us the global burden, and you can see that the sub-Saharan countries and our country, the incidence is really high. And as far as I know of, all the medical colleges in our country have special ward for preeclampsia and eclampsia. And I remember my PG days where there was eclampsia ward, 8 to 10 beds, and whole night of that resident would go taking rounds for those ladies only. So we really need to screen and not let anybody land up in that ward, I would say. So preeclampsia is a complex multi-system disorder of the pregnancy. And mind you that this increased blood pressure would be after 20 weeks of weeks of gestation. And this is characterized by new onset of this hypertension. The signs of maternal end organ or fetoplacental dysfunction is there. So we all are aware of this. And International Society for Study for Hypertension in Pregnancy has given a definition of preeclampsia that this might have one or more of these conditions. There might be proteinuria. So we check for all the ladies who come for antenatal checkups. There might be other maternal organ dysfunction, which might include an acute kidney injury. So we might find a creatinine more than 90 micrograms, or liver involvement where the liver enzymes would be raised, or the lady would come with complaints of upper quadrant pain or some epigastric burning sensation, something like that. Or there might be neurological complications like altered mental status or blindness, stroke, eclampsia, severe headaches, or there might be signs of uteroplacental dysfunction. That might be fetal growth restriction or abnormal umbilical artery Doppler or intrauterine fetal death also, or placental abruption. So these are the things that we have to look for. Now, P is a disorder that will encompass a wide spectrum of the disease, and it will have a variable onset and a clinical course. But now new thing is that if other things are present, like the neurological or biochemical or hematological abnormalities are present, or even a severe uteroplacental disease is seen and proteinuria is not there, still we would consider this lady to be in a preeclamptic state. So that is an important thing to note. Now we have multiple classifications. NICE has given different guidelines, ACOG, then International Society. But let us see, all of them have given certain high risk factors and certain moderate risk factors. And all of them start from a great history. So it is very important that we need to have a complete history. As in the previous lecture also, we heard that it is important to know the previous pregnancy details. And we need to sit and we need to know everything in detail about what happened in the previous pregnancy. So here also, all these guidelines have been telling that we need to know the history of hypertension in previous pregnancy, or does she have a history of hypertension, diabetes, chronic kidney disease, or any other autoimmune disease. Then if I go to the moderate risk factors, then is she nulliparous, or is she into a high BMI category, or any of the first relatives are having a history of preeclampsia? What is her age factor? Is she having multiple fetal pregnant? Is this a multiple fetal pregnancy, or what is the interpregnancy interval now, like more than 10 years? Then ACOG, when they gave their guidelines, they added few more factors like age. They have increased to 35 years. Then the race also came into in lower economic socioeconomic strata, then a previous small for gestation age infant. So the history points are increasing. Now, when International Society gave their guidelines, they said the BMI more than 30 comes into a high risk category. ART, the assisted reproductive technology, anybody who was conceived after ART, itself is a high risk factor. Then if you have had a shorter duration of sexual relationship prior to pregnancy, like that is less than 6 months, that is a very important point when we are considering this preeclampsia. And that's the reason we see it more in a primigravida lady, even the ladies who have connective tissue disorders. So here lies the role of a complete history taking, a detailed one, and from there you need to pick up the high risk points for them. Now, even we have a foxygestosis ICOG hypertensive disorder in pregnancy guidelines, where we have multiple things in history taking, and we give a score to them. And then we add up all these scores, and then based on that, we can tell them that this is a mild gestosis, severe gestosis, or imminent eclampsia, fulminating EPH gestosis, or eclampsia. So here is the complete summary for that history taking and the importance of it. So this is the risk scoring system. But one thing, that this risk scoring is simple because history you have screened them. At a screen positive rate of 10%, the detection rate is 40%. But the problem is it does not give a personalized risk. For that pregnancy, what is the risk for that lady to land up in eclampsia? So when Fetal Medicine Foundation came up with their guidelines, they have taken that age more than 30 years, for every 10 years, the risk increases. For high BMI more than 70 kg, for every 10 kg, you are at a higher risk. The race, the history of previous preeclampsia. If the lady's mother had preeclampsia in her pregnancy, if this is conception by IVF, or a chronic hypertension, diabetes, or she's a lady who's having autoimmune disease like SLE or antiphospholipid syndrome. So these maternal risk factors, apart from that, then when you're scanning, you have to see the uterine artery PI. When you're examining her, you have to take a mean arterial pressure and you have to take serum biochemistry. When you're combining all these things, then at a screen positive rate, you are going to pick up the preeclampsias, a very early preeclampsia, that is less than 34 weeks, up to 90%. And for a preterm preeclampsia that is less than 37 weeks, the detection rate would be 75%. And for a more than 37 weeks, it would be 40%. So this is going to give you a personalized risk, but definitely you have to work more for it. Apart from history, you have to get into examination of blood pressure. You have to go for the serum biochemistry, that is certain blood tests, and on ultrasound. You don't not only have to see the baby, you have to see the uterine artery Doppler. So we'll be looking more into details about it. Even there has been a publication comparing the NICE guideline, the ACOG guideline, and FMF guidelines. So when FMF guideline could pick up almost 100% of the ladies who develop preeclampsia less than 32 weeks, as compared to NICE picking up 41% and ACOG 94%. So in all the categories, you can see FMF picked up better. So combination of these maternal factors, the mean arterial pressure, the uterine artery, and the serum biochemistry, it was superior method as compared to the NICE and the ACOG guidelines, which was mostly based on the history taking. Now, if we speak a bit detail about these these biomarkers. So biomarkers, first I would speak upon the mean arterial pressure, that you have to take the blood pressure by the automated machines, the validated ones, and you have to take the measurements in both the arms. Average of 4 is taken and they are expressed as multiples of median. So usually all the fetal medicine people, they work with the software. So these multiples of median is being calculated by the software. But those who are not working with softwares, they can at least take the blood pressures. And when we're taking the blood pressure, we'll get to know how is it going on for that particular lady. And every visit we take. Then the measurement of uterine artery Doppler, it is to be done in a very particular way. We go for a mid-sagittal section of the uterus. The cervical canal and the internal os is identified. And we tell the transducer side to side to identify the uterine artery. The sample gate has to be 2 to 3 millimeter to cover the uterine artery completely. And very particular, the angle of insolation has to be less than 30 degree. And the waveform have to be 2 to 3 centimeters per second so that they are spread nicely so that the assessment can be done better way. Now, the notch or no notch, that is not an issue because this is based upon the trophoblastic invasion. So that is not an issue whether the notch is present or not. It is the PI that is important for us. So that is how you take the measurement of both the uterine arteries and then the mean is taken out and that is being taken for the calculation of the risk. The serum biochemistry, which I was talking about, the first thing that important we speak for screening is the PLGF, that is placental growth factor. So this placental growth factor is synthesized by the placenta, which belongs to vascular endothelial growth factor family. And this is located on, the gene is located on chromosome 14, and there are 4 isoforms of PLGF. So the basics, if I tell in very simple things, that it has both angiogenic and vasculogenic properties. So it helps that trophoblastic growth, differentiation, and invasion into the maternal decidua. So here lies the importance of PLGF in formation of the placenta. Now, this expression of PLGF, it increases in the second trimester corresponding to second wave of spiral artery remodeling. That is around 16 to 18 weeks of gestation. So as you can see on the graph, it keeps on increasing till from second trimester onwards till 30 weeks and then slowly, gradually it wanes off. So the peak will be between 29 to 32 weeks and it will fall progressively until the term. And it not only helps in the angiogenesis or the invasion of the trophoblast, but it also helps in non-branching angiogenesis so that this low resistance placental capillary network expansion happens in the placenta. So it is the expression of this trophoblastic PLGF is specifically inhibited in response to the placental hypoxia. Why am I telling this? Because all this ischemia and all problem is happening in preeclampsia state because it is a problem of placentation. So this PLGF, that is how we are going to use it for determining the risk for preeclampsia. So when we are using this PLGF in first trimester, how are we predicting? So these levels, they are greater in Paris women, they're even greater in cigarette smokers, Afro-Caribbean, South Asian and East Asian origin females. So that's how history, if we are taking it and putting it in the form when we are giving the sample to the biochemistry labs, they will have all these factors into consideration when they're giving the report. And the levels, they are lower in women with obesity and insulin-dependent diabetes mellitus. And these values are always expressed in multiples of median. And the a priori risk, which we have taken from the maternal history, the urinary Doppler pulsatility index, that is PI, the mean arterial pressure, and then to that, this PLGF mom result is added to calculate the patient-specific risk. So we will be combining all these things together to get the combined risk for assessing the risk for preeclampsia for that lady. Now, the women who will develop a preterm preeclampsia, they will have significantly lower level of PLGF. So, lower level of PLGF, you can understand that less of angiogenesis, the placentation is not good enough, and that is how the preeclampsia is happening. So, this FMF predictive algorithm, which we are using at 11 to 13 weeks of gestation, it will use the combination of this history maternal characteristics, the blood pressure, the uterine artery PI, the PAPE, which we do for the double marker, and PLGF. So that is why these days when we are sending the sample for double marker, we always give PLGF along with that. Definitely the cost increases a little bit, but it increases our sensitivity or I would say our pickup rates for these preeclampsia mothers, and it saves us on a later aspect. So this will detect 95% of the women with early preeclampsia and 46% of the late preeclampsias. Now, even in second trimester prediction, if I use PLGF, here I cannot help in preventing, but at least I can use this value to determine the frequency and how do I plan the antenatal visit for this lady and how often I call her to my OPD and what all signs and symptoms I tell her to report to the hospital. So it helps me managing this pregnancy. So combined screening between 19 and 24 weeks of gestation for this 99% of the early preeclampsia, 85% of the preterm preeclampsia and 46% of the term preeclampsia. I can pick it up. So even at second trimester of pregnancy, it is helping me out. Another thing is serum soluble FMS like tyrosine kinase. We call it as SFLT1. So it is an anti-angiogenic. So it is something opposite to the PLGF. PLGF is angiogenic. That is, it is helping in formation of those blood vessels and placentation. SFLT is anti-angiogenic and it has a central role in pathogenesis of preeclampsia. It antagonizes the activity of vascular endothelial growth factor and PLGF, leading to endothelial dysfunction. Until now, we always have been saying that this preeclampsia is a problem of endothelial dysfunction causing all multi-organ endothelial dysfunction and end organ damage. So here is the culprit. So important point about this is the increase in this SFLT1 increase precedes the development of the disease by about 5 weeks. So I've got a pretty long time to work upon or to take care of the mother. So I use this PLGF or SFLT PLGF ratio to pick up these mothers or to work upon and help not to land up in eclampsia. So this SFLT PLGF ratio, it depends upon which platform I am using. If we use this Roche platform, this will be given by the lab. So ratio of more than 85, if I get that kind of a report, then I will have a significantly shorter time to delivery to that patient. But if that ratio is less than 50 with a different platform, then definitely it rules out a PE diagnosis within 7 days and 28 days. So it is something which a fetal medicine unit would be taking care of. But this everybody should be knowing that these are new things which have come up, and we use it routinely for the ladies who require it, and we have got enough time to work upon to screen them and to help them out. And this is a nice publication which had which have nicely detail given about the PLGF and prediction and diagnosis of preeclampsia using PLGF. So using this SFLET 1 does not help me at early first trimester, but definitely from 22 weeks onwards for the particular mothers who have had history or who are having increased blood pressure, for them I can start using and predicting how much this pregnancy can be prolonged. Now, PAPE is another one which I use for my double marker, beta HCG and PAPE. So PAPE, usually it is decreased in fetal trisomies. But the pregnancies that develop preeclampsia, here also the maternal serum PAPE is decreased during first trimester. Second trimester, not significantly different. But in third trimester, early one, it is increased. So even that is helping me in diagnosing or rather screening for preeclampsia. So after all this screening, what am I going to do? We are doing all this combined screening. Combined means all the history, the ultrasound part of uterine artery PI, and this serum screening. So when I use all these things, you can see in this table that at a screen positive rate of 10%, if I'm using the blood pressure, the uterine artery PI and PLGF, my detection rate for preeclampsia at less than 34 weeks is 90%. And for less than 37 weeks it is 75%, and for more than 37 weeks it is 47%. And these are pretty high detection rates, which will help out the doctors as well as the mothers and the babies. Even at screening for 20 to 24 weeks, the mid trimester, when they are coming for their anomaly scan, here also the PLGF is being used, the SFLT1 is also used. So for less than 34 weeks, it is almost 100% that we are picking up. For less than 37, it is 85%. So that is what we have to do, so that we save the iatrogenic preterm birth and we save the mother from landing up in eclampsias. At 30-34 weeks, we minimize the adverse perinatal events. But at later gestation age, the uterine artery PI does not help me much, because without uterine artery PI, my detection rate is 97%. With uterine artery PI, I go to 98%. So here mainly the history and the PLGF SLET, they are helping me in detecting the eclampsia rates. So as the pregnancy advances, the uterine artery PI is not of much help. So here I can summarize it in table that all the trimesters, the uterine artery PI and PLGF is constant. But initial part up to 32 weeks, that is 12 week, 22 and 32, uterine artery PI is required. But 36 weeks uterine artery doesn't help me much. From 22 week onwards, SLET 1 is helping me. So this is one thing that we can summarize and keep it in our minds, that blood pressure is to be taken in all the trimester. PLGF can be used in all the trimester for screening these mothers. SLET1 and PLGF, yes, definitely these are little expensive, but I would say that putting the baby in NICU and a mother landing up in eclampsia is much more expensive thing than doing these tests. Then for late preeclampsias, maternal cardiac dysfunction is one of the important points which causes the late preeclampsias. The pathogenesis is different over here. So ophthalmic artery Doppler is a new weapon in our armamentarium, I would say. So this ophthalmic artery is embryological, anatomical and functional similarity shares with the intracranial vasculature. So if we do the assessment for this ophthalmic artery, we get to know the intracranial situation for the mother. And in pregnancies with preeclampsia, there is a decrease in PI and increase in the velocities. And ophthalmic artery is one which we can assess with bit of practice. So it is a non-invasive method, and the altered Doppler indices, they are because of the increased cerebrovascular resistance. So the peak systolic velocity will increase, and that is what we have to look for, and it can complement the uterine artery Doppler in high risk cases. So if there's a history and all these things are happening, then we can see the ophthalmic artery Doppler as well. So how do we do it? So when we are scanning the lady is in supine position. The probe is different. 6 to 15 megahertz linear transducer is used for it. And we place it transversely over the upper eyelid. We ask the mother to close the eyelid and we put that probe on the eye directly. The color flow is used to identify the ophthalmic artery and certain points that the angle of insolation has to be less than 20 degree and sample gate 2 millimeter, depth, frequency, and they all are to be adjusted. And that is how we get the uterine artery Doppler. The point is we get two peaks. Peak systolic velocity. There are two peaks for the ophthalmic artery. So this is how the... Am I audible?
Yes, ma'am, you're audible, ma'am.
Yes, yes. So when we get these Doppler waveforms, there's one first systolic velocity, the second systolic velocity, and the end diastolic velocity. So after this, we need to, I mean, the publications or the study which has happened, the conclusion is that the ratio of the second PSV to first PSV is more helpful in prediction of preeclampsia. So the PI is reduced and the second peak systolic velocity is increased. So multiple studies have been done and the conclusion is that the ratio of second peak systolic velocity to the first peak systolic velocity is helpful in prediction of preeclampsia. So it is the publications, they have said that when used alone or in conjunction with other biomarkers, it will accurately predict the future of occurrence of preeclampsia. And what is the value? So value of less than 0.72 can suggest that preeclampsia with exceptional specificity of 81%. So, but this is one thing that it is coming into practice now. Many centers have started doing it. So definitely we will have our own studies as well to add more to this. That this is definitely the newest weapon that we have. So in that table now, I can add ophthalmic artery ratio, ophthalmic artery Doppler ratio at 22 weeks and at 36 weeks. So after all this, how do I prevent this? So we all are using it now, that after the aspirate trial, we have got very beautiful conclusion that when we get the risk of preterm preeclampsia more than 1 in 100, we need to add aspirin. But then many times we do come across prescriptions where 75 milligram is given and all that. But for prevention of preeclampsia, it has to be 150 milligram per day. Even many times the patient will ask, isn't 150 milligram a bigger dose that you're giving me? But then we have to tell them that this is the only dose that will prevent you from preeclampsia. But then certain points that if this dose is being used at a compliance of 90%, then only we will have a reduction of 89 to 90% for a very early preterm preeclampsia, less than 32 weeks one. For less than 37 weeks, up to 62%. And definitely this beneficial effect is dose dependent. So it has to be 150 milligram. And it has to be started before 16 weeks when the second wave of trophoblastic invasion happens. So that's the reason we screen them at first trimester. We do all these things in first trimester, NT scan, and then we start with this aspirin and we try to prevent. And if the compliance is good, we have a beautiful reduction in rate of preeclampsia. So this table is my take-home message that mean arterial pressure in all the trimesters, PLGF in all the trimesters, uterine artery PI up to 32 weeks, and in the selected cases or previous history or the present case, if she's having such kind of issue, please try to do SFLT1 as well and try to see a PLGF SFLT ratio and try to predict and prevent. Thank you. Anything you would like to discuss further?
Thank you so much, Dr. Smita, for wonderful overview of entire prediction and prevention of preeclampsia. Over to chairpersons for the comments.
I think that was a very good presentation on prediction. And I must commend Dr. Dingley for having done that wonderfully well.
Thank you so much, sir. Thank you.
Per se, I mean, you said that the cost of SFLT1 to PLGF is expensive as such.
Yes, sir. Yes, sir.
There have been some studies which they have said that just PLGF value done appropriately at proper time can also give you a good amount of prediction.
Yes, sir. Very true. When we're doing this double marker, I mean, we can, that time only we can add PLGF. So first trimester PLGF itself, and we are, when we are putting that into our screening protocol, and if somebody is using the software for risk assessment, that time also if we get the risk and we add on to aspirin and we then keep following the lady, it serves the purpose for us. And if somebody has walked into our OPD pretty late, and then when we have to buy time, or when we have to literally see how much prolonged this pregnancy can be taken, that is the time when I would think of doing a SFLT PLGF ratio. So for a routine one, I would go for double marker PLGF and make my plan for the complete pregnancy. But for a some one or two out of them where I have to buy time and literally see and to speak to a neonatologist, those will be the ones where I'll go for SFLT PLGF ratio.
Yeah, or patients with previous history of preeclampsia, patients with previous losses. I mean,
Previous
they are the ones who
losses.
can be, and who have had previous
Few selected ones.
Yes.
Yes, selected
They are the
ones.
ones probably where things would be really helpful as such. But what has been said is that a value of 100 nanograms per ml of PLGF
Yes.
at any point of
Yes.
time will tell you that the possibility of delivery will
Yes.
be in the next 14 days. And if the level
Yes.
comes down to around 12 milligrams per ml, then the possibility of delivery is in the next 9 days is definitely there because of severe preeclampsia. So these are
Yes.
certain things which would be helpful from prediction as well as from management point of view.
True. Very correct, sir. Yes.
From gastosis score point of view, suppose gastosis score is 4, 5, 6, can we start aspirin earlier rather than waiting for 11, 12 weeks?
Sir,
Is there any advantage?
so what happens many a times, yes, ladies do walk in the OPD that yes, we are taking aspirin already. But then one thing is there, ki if it is really indicated, then yes, we have to start it. But then what is the dose? Those ladies usually come with a dose of 75 milligram or 80 baby aspirin they would be taking. But then that dose does not prevent the preterm preeclampsia. So if I have a numerical value or the risk assessment has been done and then we add a proper 150 milligram, then it serves the purpose. Moreover, this aspirin does cause a bit of acidity and other problems to the females which already are having nausea, vomiting. To that, it adds. So it's better that we do a complete assessment, and if it is required, then we add it in full complete dose. If it is not there, then there's no need of it. So it is like complete black and white, nothing in gray zone.
So ideally, it should not be started before we do dual marker and all the tests.
At least the NT scan and the prediction of the preeclampsia by all these markers and everything. And if it is required, then we start off.
Then what's the big idea of having a gastosis score of 5, 6, 7, 8, 9? It's just a prediction of what is the possibility of you getting preeclampsia in this pregnancy. Correct? And that is by history. And history will be done on the first sitting itself.
Definitely, we are keeping her on our radar. What is happening? Because a primary gravida definitely is definitely a risk patient. And then we need to see what is happening. I mean, I need to have a evidence to start.
No, there is an evidence.
Now, if I may,
Yes, please.
I am not a very ardent fan of gastosis score, although it's being pushed a lot. And in one interaction which was possible where I was able to meet the presenter in Puducherry when they were presenting, I expressed my concern that without a proper study, without a proper trial, without a proper data, if you keep pushing this, saying that it is homegrown, it may end up in harming more women than otherwise.
Okay.
Let me tell you that there is data to say that if we have a screening program for preeclampsia based on the multi-marker algorithm and you start aspirin, you would reduce the incidence of abruptio placenta in that category simply by reducing the total number of preeclamptics. Because aspirin has the complication of increased abruptio. You start aspirin on 1,000 women, compared to the normal women, you will have increased abruptio. But because you are starting on high risk for preeclamptics, your total number of abruption will come down because you have reduced or eliminated preeclampsia. That's what Smita is also trying to say. If you keep starting based on history itself, because at the most, this justosis depends on history. And history is also taken in the multi-mark algorithm. That is, history is the base. On that, you ask whether you are already having a high MAP, mean arterial pressure, your placenta is not functioning well, and your uterine artery is not doing well. So all the 4 layers are structured on history. So that gives a well-defined cohort in whom you start a treatment like aspirin, we are going to get a yield. Otherwise, we are going to get a bad yield. So I have been a very vocal proponent of multi-marker algorithm where we put everything into the resource. We are chasing behind Down syndrome. The additional cost is only 800 rupees per patient. And the savings in terms of preeclampsia or abruption is huge. So we can even motivate our patients to go for it. In our clinic, we have completely changed the protocol. It is called high yield screening, part and parcel of Down syndrome screening. Even if the referring physicians write Down syndrome, PLGF will be done. And if we use Fetal Medicine Foundation's algorithm, PLGF can be used for Down syndrome to enhance the accuracy, all those things later. To answer the question, justosis is the history component. It will have a lot of false positive if you start treating only based on history. And it can miss a lot of patients who would otherwise have other factors, biophysical, biomarker, and physical.
Thank you so much, Dr. Manikandan, for giving words to my thoughts.
It's being painted as Indian, homegrown. I mean, other things are attached. It should be pure science. I believe it should be pure science.
Yes.
And I'm not against Foxy. I mean, Bella, but madam, all those things are there. The moment you identify certain things and put a connection to other things, then science gets defeated.
Number one, I have been always a supporter of this Bayes algorithm, which is used based on history, mean arterial pressure, uterine artery, and biochemistry. And as you said, I have also had discussion, and I tried to kind of oppose this just history-based evaluation, because we know that previously NICE has also tried to do this, and it has shown that is sensitivity is just 40%. Out of so many prediction of preeclampsia, whereas mean arterial pressure even in rural area can be done. Basic ultrasound, you can do mean uterine artery PI. Just by adding mean arterial pressure and mean uterine artery PI at nuchal scan, you're not adding much of the cost, not adding much of the time, and you are improving the sensitivity from 40% to 75%. So again, I'm always in favor of a Bayes algorithm at nuchal scan as advocated by FMF UK, and I've been using it also and advocating only that.
So the example I could give you is, suppose we decide to do, we are doing amniocentesis after doing a first trimester screening in those who are screen positive. In that itself, we know many amniocentesis are going to come back as normal. At least we know that this is a high risk group, so we are justified in doing. Suppose tomorrow I come and say that anybody who is more than 25 years will have to do amniocentesis. Because amniocentesis is okay, it's relatively easy, nothing will happen in the vast majority, but it will lead to unnecessary loss of fetuses when you apply it on a mass scale. It's something similar. Unselected group, if we start applying preventive aspects, we'll end up not so good results.
Completely agree with you.
True.
Another small point I want to add regarding the dose is that 75 milligram dose is good enough to prevent, but in about 25 to 30% of women, there will be resistance, and this resistance can be overcome by increasing the dose. The resistance is due to the receptor level. So increasing the dose, the 75% effectiveness can be gone to 95% effectiveness. So I fully agree with Dr. Smita that giving the 75 dose is not correct. If you want to prevent, please go ahead with the 150, unless she doesn't tolerate, in which case it is clinically customized.
Thank you, Dr. Manikandan.
Thank you, Dr. Manikandan and Dr. Smita. Any other question regarding this? I think there are a couple of questions on cervix in this thing I see.
We've discussed
Role
that.
of, sorry, emergency tightening of cervix. Dr. Manikandan. You are muted, sir.
Emergency cerclage.
Emergency cerclage.
Where the whether or not I will offer an emergency cerclage, and whenever I offer emergency, it is going to be Shirodkar, would depend upon my clinical assessment, usually on the table. So I would tell the lady, let me take you to the OT. I will put the speculum and see if I have something to hold. Then I will put, and then I will give only 50% this thing, that whether you cross the first week after cerclage. So that's it. You will come with practice. You will know that it's a tight rope to walk, and if you get it, then you might put it. If you put it, there's a 50% chance it will succeed.
Thank you so much, both the speakers, Dr. Manik and then Dr. Smita Rengle. That has been wonderful.
Thank you.
Discussion.
Yeah, very
And
good
I'm sure
presentation.
everybody has been benefited by the same. Ashlesha, can we?
Yeah, thank you so much, all the speakers, and that was really a very scientific based discussion. Now we'll move on to our panel discussion, and I would, without much delay, I would like to call our panelists for this session. These are all eminent panelists. Dr. Rupali Dharwadkar, she is a practicing gynec at Surya Mother and Child Hospital. The second panelist is Dr. Monica Agrawal. She's a practicing obstetric and gynecologist in Her Care Clinic at Andheri. Third panelist is Dr. Dhaval Belvi. He's a consultant at the Belvi's Nandini Hospital, and he's an ex-faculty at the BDBA Hospital. Our fourth panelist is Dr. Navneet Desai. She's a consultant and director of a Shobna Maternity and Surgical Home and Joanna Mother and Child Care Hospital, Mira Road. Our fifth panelist is Dr. Jagruti Ghosh, and she is also director and consultant at the Joanna Mother and Child Care Hospital, Mira Road. The next panelist is Dr. Ashok Chukla, sir. He is a gynecologist and medical legal expert at the Sai Ashirwad Maternity and Nursing Home. Our next panelist is Dr. Seema Rai. She is a consultant and senior consultant and director in Navjivan Nursing Home for last 30 years. And our last panelist, Dr. Sarita Channavar. She is a consultant obstetrician gynecologist and infertility specialist at Wokat Hospital, Mira Road. So I really welcome all our panelists on this reverse panel, and I would just request Dr. Bela Bhatt ma'am to go ahead with the panel discussion.
Thank you, Ashlesha, for such a wonderful introduction for all of us. And at the outset, I would like to thank Bela Madam and AFG for organizing such a beautiful discussion platform. The talks till now have been superb, and I know the panel will be excellent too. Thank you.
Thank you so much, Navneet, and I welcome all the panelists.
And have all the best for your election.
Thank you so much. So I welcome all my eminent faculties, panelists, Dr. Rupali, Dr. Seema, Dr. Navneet, Dr. Sarita, Dr. Ashok Shukla, Dr. Dhaval Belvi, Dr. Monica Agrawal, Dr. Jagruti Ghosh. I'm sure our interaction is going to be useful to all of us.
Yes.
So yeah, let's start discussing about aneuploidy screening. We know these days, I mean, every day we offer aneuploidy screening to all because it's universal. We know that. So, and once the results are in hand, we have a lot of confusions. So let's try and discuss it out and solve our queries and confusion. Yeah.
So this is a very interesting panel where we ask the questions and the moderator is there to answer us.
Thank you. Let's try and discuss
Dr. Navneet, you can go ahead with your question now.
So I have a very different question for you, ma'am. Ma'am, what is the role of NIPT for microdeletions?
Directly jumping on NIPT microdeletions.
Yes, madam. Now she has given me that comment.
We have many basic questions, but let me answer this.
Basic screening.
Yeah. Who's that?
Sarita. Dr. Sarita.
Yeah, Sarita, tell me. Then I'll come to your question now, Dr. Navneet, for sure.
Okay, ma'am.
Yeah.
Yeah.
So, which of the screening test is the breast screening test? Whether knuckle scan, double marker, or quadruple marker test?
So, whenever we offer any screening test to any patient, what is important is the two things are important to look at what gestational week we are offering and what is the sensitivity of that test. These are two important things. Now, as we know, nuchal scan alone has a sensitivity of 80%. Double marker alone has a sensitivity of around 60%. But when we combine both, the sensitivity of combined test is around 90% with false positive rate of 5%. Not only that, it is offered at 11 to 13 weeks, 6 days. So first trimester screening. As compared to that, quadruple marker is a second trimester screening test, which is offered from 15 weeks to 20 weeks. And it is a little lesser sensitivity, close to 80%, right? 80, 81%. So when I have to look at the universal screening for all, I would look at a test which gives me result a little earlier with a better sensitive test. So combined test, that is nuchal scan plus double marker, is a good screening test that can be offered universally. We know this, like we have all strata of patients, right? Having said that, we'll discuss about NIPT and all because they are better screening tests. But yes, for universal screening, this first trimester screening, because of the earlier result and better sensitivity test, is a good screening test. Yes.
Madam, hi, Dr. Dhaval Belvi here.
Hi,
Thank
Dr.
you
Dhaval.
for having us as a part of your panel. Madam, I have a question. How do we interpret this double marker test?
Yeah, that's a very good question because see, the minute there different type of practice is going on. Somewhere those who are doing ultrasound and everything, they do nuchal scan and the same day the double marker is sent and then the report is combined and already combined report is given. Somewhere the report is done with a sonologist, the reports goes to the genetic lab for double marker and the report comes. Now what is important is never look at the report of double marker as a double marker report because before only I said that the sensitivity of double marker alone is just 60%. It has to be a combined test. So even if you are sending it to lab, a good nuchal scan report has to be sent with it so that the lab will combine the ultrasound markers with the biochemistry and will give a combined risk, which has a good sensitivity. Then only on basis of that, we are going to counsel our patients. That is first thing. Second important thing is, whenever we look at your nuchal scan report, what is important is in the double marker, looking not just at the risk calculation, but to look at the MOMs of beta HCG and PAPE because that itself will give you a lot of information. Like we know that when the MOM of beta HCG is more than 2 MOM, combined with PAPE, which is less than 0.5 MOM, then we know that this fetus is going to be at a higher risk for Down syndrome. When if we see, look at the MOMs and they are both less than 0.5 mm, beta HCG and PAPE, then we know there's slightly higher risk for trisomy 18-13. Now, having said this, we should also remember that this beta HCG and PAPE are not just the markers of aneuploidy screening, but they are also overlapping markers of placental insufficiency. So, there are many fetuses in whom low beta HCG and PAPE is because of the possible placental insufficiency. These are the patients who are going to be at higher risk for preeclampsia and fetal growth restriction rather than aneuploidy screening. But because these are overlapping markers, you will get high risk for this as well as preeclampsia FGR. But this is something just by looking at the MOMs of beta HCG and PAPE, you will get the idea. So don't just jump to your last page and look at the risk calculation. Look at all the parameters and then have the idea about the report.
Dr. Bela, ma'am, can I ask one question? See, for the double marker test, as you rightly explained, but if the MOMs are in the abnormal value, and if we have the probability which shows that it is, it is a low risk. Sometimes we have those kind of reports where the probability is say 1 in 5,000 or 1 in whatever, but the MOMs may be not normal, which would suggest that that could be a probability of a chromosomal anomaly. So do we in such cases refer this patient to a fetal medicine person or recommend for an invasive testing? How do you take this further?
No. So the thing is, when we combine the combined test and double marker, if all the nucleus scan no markers are positive, right, for NT, NB, DVTR, and your biochemistry is abnormal, as I said, more than 2 MOM 0.5, it will give at least intermediate risk. It will not give complete low risk. It will not give complete low risk. It would give you at least intermediate risk, in which case you can counsel the patient for at least NIPT. Right? If it is not falling in the high risk category, but you have a better screening test, if you do not see anything on the ultrasound, no markers, no structure anomaly, growth centiles are okay, and your biochemistry is altered, you have another better screening test for trisomy 21, 18, 13 at least, and you can always offer that when you look that the biochemistry doesn't look good and scan is looking okay. Yes, that's a better screening test, which will at least help us rule out trisomy 21, 18, 13 with good sensitivity.
Oh, thank you.
Yeah. Bila Madam, this is Dr. Ashok Shukla here. Thank you for having a panel which we are asking question and you are answering. And the beautiful part of this program was it's things which are seen in day-to-day practice by gynecologists, because we do face such challenging scenarios. So if the combined test comes in the high risk zone, it's the gynec role, how to counsel and proceed, because then the lot of questions get fired from the patient side and the husband side, because nobody wants an abnormal child to go ahead. And then how to counsel such patient and what next we should do.
Now, number one, for any screening test, a pre-test screening and post-test screening, both are very, very important. So in pre-test screening, we should have explained to the patient that if it turns out to be high risk on this, I'm going to offer you diagnostic test, which is going to be invasive test. That is one thing patient should be knowing before you offer the test. Now, what is the cutoff that you use for your high risk is a different issue. Majority of the centers in India still use 1 in 250 as the cutoff, but there are centers that have now decided 1 in 100 as cutoff, right? In South and all. So there, more than 1 in 100, they would offer invasive. Beyond that, if it is between 1 in 100 to 1 in 1000, they offer NIPT because that's a better screening test. And so they are trying to reduce the number of invasives basically. So here, if we are using 1 in 250 as a cutoff, fine. If it falls in high risk, now again, when you are explaining the result to the patient, we have to explain based on the number that we got based on the combined test. So rather than using the word high risk, it's better to use the word high probability or high possibility. That there is a high possibility that this baby has this problem. And because it is high possibility, if you want to be 100% sure about whether your baby is having trisomy 21, 18, 13, whatever it is showing the high risk for, I will offer you a diagnostic test, which will be CVS now or amniocentesis at 16 weeks onwards. And as I said, if it is intermediate risk, we have another option which is there. But you asked about the high risk. So you can always. Now, there will be patients who will be little at 12 weeks. They are not ready for CVS. They feel that, no, madam, do we have any other option? We don't want to go for needle test now. These are the patients where again our NIPT comes into play, because that's a secondary screening test with a higher sensitivity, mainly for 21, 18, 13. So you say, yes, if you do not want a needle test now, NIPT is a test. If that turns out to be negative, there's a very, very low possibility, less than 0.1%, that baby will be abnormal. So we can do away with needle test. But if the NIPT again turns out to be positive, it is still a screening test. And therefore, then I will definitely offer you a diagnostic test. So that is what we can tell. And in such patients also, there are some patients in practice, we get all kind of patients. Some patients who wouldn't want either of it. We can wait till 15 to 16 weeks, do another early anomaly scan, because sometimes it happens so that some of the structural defects may appear. Some of the markers which we look at in the anomaly scan, 9 markers for Down syndrome and all, may appear at 15, 16 weeks early anomaly scan. Then we can take a call that now you have such and such thing. So we must go for amniocentesis and microarray.
And I think so it should be documented well also on the paper.
Always.
Because a lot of time when you tell, then the patient sometimes runs away to some another person, and maybe tomorrow he'll say we were not counseled properly.
Very true. Documentation at every point is very, very important, because there have been cases also we have read in newspapers where the patient, the baby turned out to be Down syndrome, and the patient sued that they were never offered any screening test, though the
Yes.
doctor had offered but not documented. So it's very, very important that refusal of screening test or a particular test should be documented. And you being medical legal person, I am sure you would make that point clear. Yeah.
Okay. Good evening, Bela madam.
Yes, good evening, Dr.
Yeah, Dr. Jagruti here.
Hi, Dr. Jagruti.
So I think dual marker, everything is covered by now. And the last was medical legal concerns. So I think we should discuss on quadruple marker now, madam. And what do you think? Quadruple marker should be done only when the dual marker is missed, or it should be the test of first choice? And can it be done in all the patients?
Okay. So definitely not for all the patients. That is first thing. If the first trimester screening has been done, now when I say the first trimester screening has been done, quality control is very, very important. So what do I mean by quality control? Nuchal scan, which has been done in a standard manner. So it's our duty to have a look at the images, whether the CRL has been taken in a standard manner, whether the anti-NB image is standard, because then only that nuchal scan or the sonographic markers can be taken into account, right? Otherwise, that nuchal scan is just a viability scan or just to check the growth of the fetus at that particular weeks. It's not a nuchal scan. That is one thing. Similarly, the double marker should have been done in a standard lab that asks for all the factors and takes into account all the factors and the nuchal scan and gives you combined risk. Okay, so that is first thing. Now, if the nuchal scan has been done in a standard manner and if it is showing low risk, then there is no point in doing quadruple marker. Why? Because in a screening process for aneuploidy screening, we always step up and never step down. So I have done a screening test with a 90% sensitivity at 11 to 13 weeks. Now, what is the point in doing a test with 80% sensitivity at 16 weeks? It will not add any further value to my screening process, right? Had it been intermediate test wherein patient refused for NIPT, there is still role of quadruple with a good early anomaly scan. But if it is a low risk, done in a standard way, no point in quadruple. And second indication of quadruple would be, obviously, if the patient has missed the first trimester screening, we have nothing in hand, I will do a good structural anomaly, early anomaly also, because patient has missed first trimester screening, patient has also missed the nuchal scan. So some of the anomalies, 50%, 40%, whatever we can pick up at nuchal scan, patient has missed that also. So I'll do a good anomaly scan at any point, whether it's 11 to 13 week screening or it's 16 week screening. A good structural scan is very, very important. Because why it is important? Because if there is a structure anomaly in the fetus, then I will not offer any screening test to this patient. I'll offer directly the diagnostic or invasive test. So no point in quadruple then, no point in doing an IPT then. Then I'll directly offer a invasive test. So a good nuchal scan with structure anomaly scan or a good early anomaly scan, both whenever the patient comes, is the first step or the first screening test. And then based on that, I'll counsel the patient whatever test the patient can be offered.
I just wanted to add,
Yeah.
Can I?
Yeah, please.
Yeah, I just wanted to add one thing because it's connected what I was thinking. The one thing is because a lot of time we have patients who come at 6-7 weeks and suddenly somebody in their family is sick, they go to their hometown, suddenly they are not able to get the nuchal scan. So they come late. So as you already mentioned, then a good scan should be done, good anomaly scan. So I just wanted to know what is a good anomaly scan, for the whom I should say it, because a good anomaly scan or a good nuchal scan. So that is because a lot of times then we have to insist the patient that
As far as the nuchal scan is concerned, if you get number one, as I said, it's our duty to look at the images. Look at the CRL, look at the anti-NB image. We must know what are the standard images. By now, it has been hammered on every obstetrician what is the standard CRL image. wherein the fetus occupies 75 to 80% of screen, mid-set section, neutral position, both crown rump seen, and the CRL has been taken. I still see so many reports where in one corner, small fetus is seen, two dots are put, and that's a CRL. No. So there are many reports wherein entire fetus is seen and they have measured NT. Big no. It is only head, upper chest, magnification up to 75 to 80% of the screen, mid-set section, neutral position, tip of nose, nasal bone, square palate, diencephalon, thin nuchal membrane, and the NT measured. These standard images, two images are must. That is one thing to look at it, whether it is a good nuchal scan, whether it is FMS certified, not, put it aside. But at least these two standard images is something which is very, very important. Why FMF UK certification is important? Because those certified sonologists will also give you the risk calculation for 21, 18, 13, which the other sonologists will not give. So what is the fun in doing a nuchal scan where you do not have the risk for 21, 18, 13 in hand? They just write NT 1.2 millimeter normal, NB present. But where is the risk calculation? For that, they have to do certification, and internationally it has been accepted by everyone, FMF UK certification. So just they have to send the 3 images to the FMF UK online and get certified. So I think that is the least which should be expected from anybody who does a nuchal scan.
Very well, very well.
Ma'am,
Good evening.
Dr. Monica here.
Yeah.
Hi, I'm Dr. Seema. Hi, Dr. Bela. It's really privileged to be a part of this esteemed panel and very happy that it's a reverse panel where you're answering all the questions. So, Dr. Bela, I just wanted to know one thing. Patient has done the nuchal scan and now it comes as high NT. So now, how do we proceed? Should we ask her to do an NIPT or a direct invasive amniocentesis and genetic testing if the NT is high?
One thing is, when we say NT is high, there are two things. We'll always look at the centiles of NT nuchal scan for that particular CRL. NT is a function of CRL. So at 45 millimeter CRL, the NT centiles 96, 97 is different. And at 84 CRL, the centiles of NT are different for calling it high. So first thing I'll see what centile it is. Is it between 95 and 99 or it is more than 99 centile? These two are different categories. So if it is between 95th and 99 centile for that particular CRL, again, I would have looked at other markers, NB, DB, TR. I would have ruled out other structural anomalies, especially any cardiac anomalies, any mediastinal structure defects, masses, etc., because they can also give rise to high nuchal translucency. So we have to rule out structural anomalies. We have to look at other markers. And if there is nothing else, and it is between 95th and 99, I will combine it with the biochemistry because it will add value to it. And then whatever is the final number, whether it falls in high risk, intermediate risk, I can counsel. That is one way. If the NT is more than 99 centile for any CRL, more than 99 centile, that the report should give you, then it's a different category. Then there is no role of any screening test and direct invasive test has to be offered, not even NIPT. Why? Because when the NT is more than 99 centile for that particular CRL, chances that the fetus will have some genetic condition other than 21, 18, 13 is very high, in which case your NIPT will show low risk, but invasives will find out some kind of genetic condition. So that will be a false negative NIPT. Right? So when it is more than 99 centile, yeah.
Between 95 to 99 also NIPT or the combined risk, the dual marker?
So in between, as I said, I'll add the biochemistry, I'll look at the number and counsel. If it is falling in high risk, I will offer the invasive test. If it is falling in the intermediate risk, I will offer first NIPT. Or we can even, as I said, if the patient is not ready, we can wait till even 15, 16 weeks also, reassess the fetus, look at the other markers, structure anomaly, take a call for amnio and micro.
One question I had here was, Dr. Navneet here, yeah. Ma'am, one question I had here was, when we do an NT and instead of a dual, we can directly do an NIPT?
That was what question?
Good question. So The information that we get from NIPT is mainly for trisomy 21, 18, 13, right? So you do your nuchal scan as a primary scan. There is no structure anomaly, nothing. And now you want to add it as a better screening test for trisomy 21, 18, 13. Yes, you can add. If the cost is not a problem, you can offer a good nuchal with NIPT. But I would say that I would offer combined test with NIPT. Why? Because beta HCG and this double marker beta HCG PEPE is also tell me about the high risk for preeclampsia and fetal growth restriction along with uterine atrophy and maternal demographic. So I just don't want to look at the fetus. I have to treat my mother also. So I am also worried about the preeclampsia and FGR, which is going to happen in the pregnancy. So I want the risk for trisomy 21, 18, 13, preeclampsia, fetal growth restriction, everything. So putting together everything, the best screening test would be a good combined test with NIPT. And these days, as Dr. Smita has very rightly mentioned, many centers have also added PLGF to it to improve the sensitivity of a preeclampsia. So if cost is not a problem, the best screening is offer everything. Let the patient decide how much they want to spend on screening.
Ma'am, in case, ma'am, Dr. Monica here.
Question.
Ma'am, Dr. Monica here. I have a question.
Yeah, Dr. Monica.
Ma'am, if the early anomaly scan is showing absent nasal bone, so in that case, what should we do? We should go with the, as you said, with the double marker and then think of amniocentesis, or directly we can go?
No, so nasal bone number one, first of all, the CRL, it is better if it is CRL more than 55 or so, because before that, there are a lot of, sonologist variation also in the, we're calling it hypoplastic absent, etc. So if it has been documented as unossified nasal bone in the nuchal scan, again, yes, it's better to look at the other markers and also combine it with the double marker, that is beta HCG and PEPE, and based on the combined risk, I'll counsel the patient. Especially in our Asian population, it has been seen that only unossified nasal bone is, though the risk, the risk that it increases for Down syndrome at your anomaly scan is 6.7 times. But in Asian population, at the same time, we do find unossified nasal bone in many euploid fetuses as well. So I will always use it as a combined algorithm. I'll look at the other markers, I'll look at the double marker, and I'll put in all the values, look at the number and counsel the patient. Or second way is to offer, we can always offer NIPT. As I said, it's a better secondary screening test. So that is one option, but you counsel the patient, offer the patient, let the patient take.
But she may need amniocentesis later on. So better to do double marker and then she can opt for amniocentesis.
That's what.
Yeah, right. And ma'am, one more thing.
One question. Yeah, please, Dr. Monica. You can.
So
yes, Sarita, you asked first.
Okay.
No, let Dr. Monica continue.
Yes.
So it is just related with this only. So if the double marker is showing intermediate risk and patient doesn't want to do NIPT, should we offer quadruple marker to her, or there is no value to it?
No. So again, as I said, double marker alone, you mean, I think, combined test, not double marker.
Yeah, combined test. Yeah, the first
combined test. So combined test is intermediate risk, you are trying to say, and patient doesn't want NIPT. Yeah. So here I would, in the second trimester, you can offer quadruple marker, but along with your good early anomaly scan. That combination will be still better, because there you can get information on the 9 markers of the Down syndrome as well. And then you can combine, that's also called second trimester combined test with at least some 80-85% sensitivity. So that will be a second tier of screening test, but not just quadruple marker. We have to add early anomaly scan to it, because then we'll be ruling out some of the markers, structural as well as chromosomal markers.
Okay. Yeah, got it now. Thanks.
Bella ma'am, I had the same question. If it is an intermediate risk on dual marker or the combined screening, then what next to be done? I think Dr. Monica asked the same thing.
Yeah, I think we have
already discussed. Yeah.
Dr. Rupali has been trying to ask questions since when? Yeah, Dr. Rupali.
was just waiting for everyone. The discussion is so good that all my questions are answered. So, since we are seeing a lot of multiple pregnancies and all because of IVF or IUIs, which we are doing, so we sometimes come across vanishing twin on early trimester scans when we do. So, how far the combined test would be a logical, or how do we interpret it, considering that in a vanishing twin, we will have a PAPA report which would be higher compared to the normal singleton pregnancy. So, is there a difference in interpreting it, or whether the lab should put in the different scores and then we should send it to the routine lab, or are there any special labs where we should send the sample to so that we get the accurate report?
Thank you so much for that question. Number one, whenever there's a vanishing twin, wherein there are two types, wherein the two fetuses are seen, one fetus with cardiac activity, the other one is without cardiac activity. Now, these are the patients wherein we will just do nuchal scan based screening. We will not offer biochemistry for sure, because as you mentioned already, the dead fetus would contribute to the biochemistry, mainly the PAPA, and therefore there will be false negative, false positive, right? So here, whenever there is a vanishing twin with one fetus without cardiac activity, I will do just a nuchal scan based screening. And I'll tell the patient that this is the only and the best thing that I can offer as far as screening for aneuploid is concerned, because biochemistry will be not correct for screening. And now, if you find there is one sac with one fetus and the other sac is completely empty without any fetal pole, now here we can offer our combined test, right? So there we can use our combined test. Now the same thing would be true for NIPT also, because the basis of doing NIPT is also based on the placenta or the placental mass and the DNA that is apoptosis has occurred from the placenta. So if there is a vanishing twin, better not to offer NIPT to this patient, because that dead fetus would also contribute to the DNA fragment. So the anti-scan based screening is the only that we can offer when there's a vanishing.
Right. So, ma'am, now coming to my question about micro deletions. I recently have a patient, that is why I'm asking you repeatedly.
Yeah. So NIPT nowadays, so many labs are offering so many micro deletion, duplications, etc. But as far as validation is concerned, it is trisomy 21, 18, 13. And in micro deletion, 22 to Q11 micro deletion. It is mainly validated for only this micro deletion. So if ultrasound based suspicion is there, there is right-sided aortica, there is some cardiac anomaly where you suspect 20Q and you feel, then you can specifically tell the lab for that particular microdeletion. Rest, all, there is no robust data as yet, and therefore the sensitivity is little questionable. So for all practical purpose, you can go for your routine NIPT for 21, 18, 13. That's good enough. No need to go for that extended microdeletion duplication till we get the robust data and validation.
Okay.
Can I ask?
Yes, sir.
Yeah. So, Dr. Bela madam, a lot of time what happens ki we send the patient for an NT scan, and when the patient comes with the NT scan report that day, same day, we send the double marker. Now the patient dual marker, and the patient will come for follow after 20 days. We inform the report, we'll say aap jaiye, we'll inform on the phone how things are. Now, whenever the receptionist or the doctor, whoever calls about the report, patient after hearing everything asks only one line, sir, sab normal hai. Now, how to counsel? Because on the when they come also on the physical visit, next time when they collect the physical report, again the husband says, we say 1:250, 1:750, 1:, this. They say, sir, koi tension nahi, sab normal hai. So because see, we also know ki, if it is, chances are low, that doesn't mean it is 100%, 0% chances ki it will not happen, and sometimes happens. So how to take care of ourselves while when you are, or indirectly, how to counsel in a simpler word so that we are also safe from our side, medico-legally, as well as a gynec.
So I'm so thankful to you for raising this point, because this comes as a part of post-test counseling, right? When the patient comes, and it is very, very confusing. For obstetrician also, it is confusing. So patient, it's extremely confusing to understand about the result. So now, as you said, if it is low risk, that means more in 1,000. So maybe 1 in 1,100 or something is the report. That is a low risk. So number one, we should have told before and only that these are screening tests. So that will only give us a number, and it can never be zero, because these are not diagnostic tests. So typically I tell patient, मैं baby का blood या fluid नहीं ले रही हूँ, which is a diagnostic test. पहले हम screen करेंगे whether कोई markers है जिसकी वजह से possibility high है common chromosomal problems की. अगर possibilities high आएगी, then I will offer you direct test or a diagnostic test or a needle test after the result. And after the test, what is based on, I mean, if it is low risk, I will tell that, see the number. So basically we are supposed to explain about the number, 1 in 1,100, 1 in 1,200, etc. So when the number is 1 in 1,100, I'll say that with this sonographic markers and with this biochemistry, your baby having possibility of Down syndrome or trisomy 18, whatever, is 1 in 1,100. That means 1 out of this 1,100 will be affected, whereas 1,999 fetuses will be not affected by that. But that 1 in 1,100 still remains, and if that is going to be your baby, it is just your bad luck, because still low risk and still you can get, but you may get. This is not a diagnostic test. This is just a screening test. And if you are very, very anxious and you want to be 100% sure, then you have to go for amniocentesis and take a whatever small risk of abortion is there, which is there. So with this clear cut, this thing, if you put it in front of patient, I think patient usually understand.
And ma'am, one more thing. Now, when we have this abnormal combined tests and all these things, and we tell the patients to go for an invasive test, they said, do we have another alternative? And as we said, we to say NIPT. So then, isme to 100% sure hoga na. Again, we are giving a 99%.
So I always tell.
Why is this NIPT existing? My question is, let's.
NIPT is a very good test, let me tell you, but
it doesn't give us 100%.
I'll tell you what is the reason why it is a good test is. NIPT is a screening test with the best sensitivity for trisomy 21, 18, 13, 99.3% for 21, and for 18 and 13, 96 to 97%, which is higher than that of the combined test. Now, the better part of NIPT is very low false positive, less than 1% false positive. What do I mean by false positive? The false positive of combined test is 5%, with all markers maybe 3%, whereas that of NIPT is very, very low, less than 1%. So, false positive are the patients whose fetuses are euploid but falsely positive, with falsely positive report, in whom we are going to do needle test or amniocentesis. So, these are the patients who may have a small but increased risk of abortion. So, if you want to reduce the number of invasives, you want to reduce the number of abortions, then NIPT is a good test, because the false positive is very, very less. Even if it is positive falsely, it is less than 1%. So in only very few fetuses, I am going to put in the needle and I'll increase the risk of abortion. Whereas with combined test, I'll put in that 5% of falsely positive fetuses, I'll do invasive test. Do you understand? So this difference in less false positive is good. And it is especially important in twins. If it is both live twins, dichorionic, diamniotic, monochorionic, whatever it is, if you offer NIPT, it is better in twins, because in twins, if it comes out to be for one fetus also, it is high risk. I'm going to put in needle in both the fetuses. As such, twins, the risk of abortion is high. By putting in 2 needle, I'm further increasing the risk. So if I offer NIPT, and if it turns out to be negative, screen low risk, then I will do away with that needle test, which will be more in cases of combined test as compared to NIPT. So NIPT has its role in reducing the number of false positive, in reducing the number of invasives. So it is a good test, for sure.
Ma'am, since we are talking about the risk of amniocentesis, should we take consent of the patient when we advise amniocentesis to the patient? Should we inform them that there is an increased risk? And as a since you do this is such procedure, do you take consent? Because we usually send it
Always.
for okay. We should all
Always. There is a
the
3-4
observation.
pages consent
So
which
that is
mentions about everything. A small risk of abortion, a risk of infection, risk of leaking, risk of spotting. Everything is listed. They sign it. And not only that, I always counsel before procedure that there is a small. In the experience end, the risk will be less than 1 in 500. But there is a 1 in 500. There are cases there where there has been abortion. It is very less. Sometimes less than 1 in 1,000 also after once the the procedure is uneventful, but that 1 in 1,000 still remains. It's not zero. So risk of abortion, we have to explain to the patient, but I tell them, this is the risk. So we do it only in high risk patient, right? So there the risk for trisomy 21 is say 1 in 50. And the risk of abortion is 1 in 500. So you look at the risk of your aneuploidy is higher than the risk of abortion. So you would want to rule out that aneuploidy or that condition rather than, so you have to take that small risk. They have to take that small risk. We have to counsel. And then only after taking signature, only we do the procedure.
Okay, ma'am, one more question I have. Since we are a lot into IVF conceptions, we're seeing a lot of people going into it. So what would you recommend, which would be the best form of, combined test or an NIPT, considering that when they go for IVF, most of these PAPA and everything is affected because of the procedure per se. So what would be your take?
Thank you so much again for that question, because IVF conceptions are increasing. So screening for IVF patient is important. Now, whenever we send this, first I'll clear that whenever we send this double marker to the lab will correct. That's the reason the form mentions whether it's spontaneous conception or IVF conception, because lab would correct the MOMs of both beta HCG and PAPA based on whether it's spontaneous conception or IVF conception, right? So that part is out. Now, having said that, because IVF conception, they have higher risk for preeclampsia and FGR as well, I would want a combined test for sure, right? Nuchal scan and double marker beta HCG and PAPA for sure. If you can add PLGF, very good. And because these are the patients who have conceived after a lot of treatment and after a lot of spending money and a lot of mental, everything, emotional status and all, you offer the best screening test for Down syndrome as well. So a combined test with NIPT, if cost is not a problem. They have already spent so much for IVF. Why not a good screening for trisomy 21, 18, 13, structural defects, preeclampsia, FGR, everything. So you offer everything to them. And most of them agree also these days. Many centers, they do with combined test, NIPT also. So that they have the best screening test for trisomy 21, 18, 13, along with best screening for preeclampsia and fetal growth restriction.
So for you, all patients, suppose you have n number of patients walking in who are having IVF conceptions, would you really tell them or offer them that combined plus NIPT is what you give advice?
Sure, I would offer. Then depending upon whether they want
financial constraints, they would.
Yes, financial constraints, if they want, fine. They do not want,
they
that's
opt.
up to them. That's up to them.
Can I ask you one question, ma'am?
Yeah.
Yeah. The question is like you have undergone the invasive test, amniocentesis, and you have sent a sample for microarray. And can the result evolve? Like you were suspecting very high, and the result has come, and you are told lab to check again. And can it revolve? Like you will get a different report or something.
That is more
Yeah,
common.
what are the possibility? Like it's a
That is more common. See, there is in science, nothing is 100%, right? There can be false positive in amnio also, though the chances are very, very less. But that is what you said is more common when CVS shows some abnormality, and when you do amnio, it rules out that abnormality, because that is because of confined placental mosaicism. What is mosaicism is, there are two cell lines. One is abnormal, one is a normal cell line. So in placenta, it happens, we know that CVS, we take a sample from the placenta, wherein there are two cell lines. One is normal, one is abnormal. So if from where you have taken sample that is abnormal for trisomy set 18, 13, the report will come as positive for trisomy 18. But then on scan, I'm not seeing any abnormality. So I'm little skeptical whether this fetus is really affected. I will watch till 16 weeks, again reassess the fetus, and then I do a amnio. And if I confirm, and the report would say mosaicism. So if they say, then I would repeat a amnio and try and rule out, because if the fetus looks structurally normal and this is mosaicism, then yes, amnio, because amnio has more cells directly from the fetus. It's not from the placenta. It is fetus skin cells from the urinary and the respiratory tract. So these are true fetal cells. So there are less chances of, mosaicism in case of amniocentesis as compared to CVS. So then, yes, if I do amnio, yes, Dr. Pal.
And one more thing, when you go for invasive tests for this amniocentesis, what are the things we should ask from the genetics for the testing? Like microarray, anything else? Like how?
Yes, as I said, because the microarrays are broader spectrum, many centers have directly gone for, they go for microarray because common structural anomalies that a karyotype pick up, plus some of the common microdeletion duplications, microarray will pick up, will give the report within 14 days. 14 to 50 days. So many of the centers directly go for microarray. If you don't pick up anything on microarray, DNA storage is a good practice, because as I said, as the fetus grows, sometimes some of the structural defects may evolve, which in which case you can test based on that DNA storage.
So according to you, Bela, which is the best platform could you suggest? I mean, for this screening test, dual marker and all. So is it, are all the platforms equally good, or do you prefer one over the other?
So we look at standard genetic labs would use the standard platforms, Roche, Autodelphia, right?
So they all are equally good.
Yeah. These are good platforms, and they use standard reagents, standard platform, and all the variables which affect MOMs, history, and conception, medical history, obstetric history, IVF conception, singleton, twins, everything they take into concern. So any lab which is not asking for all this history, you should not send.
So we have discussed different scenarios.
Can I ask?
Yeah, sure.
What is your take, Dr. Bela, on combined test in a DCDA and an MC twin?
Yeah, again a good question. DCDA, because we know that there are two different placentas and there can be two different chromosomes of both the fetuses. The result of combined test, we can offer combined test, but the result will be per fetus. The risk will be per fetus, fetus A, fetus B. The risk will be different in both the fetuses. Whereas in monochorionic, 99.9% we know that the chromosomes are going to be same, and therefore the result will be per pregnancy. Both the fetuses will be having same risk for trisomy 21, 18, 13. And that is the lab counts based on average of NTs. Suppose one is slightly higher, some is slightly lesser. It will average out the NT, combine it with the biochemistry, and will give risk per pregnancy for monochorionic. Whereas in dichorionic, they'll take the NT of A plus biochemistry and risk, NT of B plus biochemistry and risk, because the chromosomes are different.
And NIPT, I don't think can be of any significance in a DCDA, right? How will we?
We can do, as I said again, we are happy when there is when there is low risk NIPT. Then I don't need to worry about both the fetuses. If it turns out to be positive,
maybe I have to.
Then I have to put in 2 needles. That's a different issue. But at least in negatives, I'm low risk. I'm not worried. I don't need to do anything.
Because since it is going to take the fetal DNA, we don't know what they are as, which fetus they are as.
That's why. But when it is low risk with good fetal fraction, low risk, I am sure that both the fetuses are not affected. If it is positive, I don't know which one is affected. So I have to put in 2 needles.
And just a general question, because since you're so experienced in this and you're doing amnio and all, till date, how many of high-risk double marker tests which you have got and you have done amniocentesis, the results have come positive? Because what in my practice, whatever 17, 18 years, the number of amniocentesis, whatever were referred, they never came out positive. All were like normal, but the double markers were abnormal. So what is your experience in this?
So this is again a very, very pertinent question, because that all depends at what cutoff do you decide that this is high risk. If I put my cutoff as 1 in 50, I'll get very good, very many of them would be positive. If I put it as 1 in 250, I am going to get more of false positive. The report is going to be normal, right? So that depends on whether you want to miss out on those Down syndromes which are there between 1 in 100 and 1 in 250, or you are ready to take that small risk of invasive test and abortion and you don't want to miss out on that. Yes, there have been, when there is a numbers which are as high as 1 in 10, 1 in 50, 1 in 75, have got positive results. I have got. But when I do it close to 1 in 75, 1 in 200, there are very high chances that I would not get positive result. So that this depends on what cutoff you decide for your invasives.
So it's better to err on that side, because bringing up a
If
down.
you don't want to miss out those in between because the maximum number is between 1 in 250. So if you don't want to miss out between 100 and 250, that additional small risk of invasive test is fine. I would not want to miss out on that.
Correct. Thank you. Thank you so much.
Thank you. I think we've had a very good discussion.
One last question, Dr. Bela. In patients with high BMI, above 30, again, there are chances of high false positives. So do we have to resort to any special test, or just the combined first trimester test would suffice?
Thank you. Last question, but a very good question. High BMI patient, no NIPT. Because we know that NIPT is a test which is based on fetal maternal fractions of DNA. And those who have high BMI will have so many higher load of maternal DNA that the fetal fraction is going to be very, very low. When the fetal fraction is less than 4%, we are not going to get the proper report of NIPT. So we do not do NIPT in obese patients. It is then only combined base.
But how high BMI, madam? What is the cutoff for that BMI?
More than 25 also I don't do. I tell patient that I wouldn't offer because there are chances of false positive, negative. Fetal fraction can be low. So I don't offer.
Thank you. It was lovely, wonderful discussion.
And one last question.
Conclude our session now. We would like to conclude our session now.
We will not want to leave Dr. Bela.
So many questions.
I know, but as somebody has been calling me repeatedly, I said 5 minutes, I'm coming. I will discuss Monica for sure over dinner.
Maybe
Thank you, madam, for that interactive webinar. And
well, let me first thank all the panelists, because it was wonderful interactive section, because of which we could get so many clarity on so many issues of aneuploidy screening. Thank you so much, Dr. Ashlesha, who's MOC of this entire event, for conducting it so well. And of course, thanks to all the faculties of this webinar. Yes, anybody?
And gentle reminder for the ma'am's election for the vice president post. So really, we really need your
Dr.
help.
Smita, thank you for being there till end. You are muted, Dr. Smita. You're muted.
I have to be here. I can't leave you.
But then I would have included in that discussion.
Oh, no, but it was going on so well.
Thank you so much. And
thank you and all the best, madam.
Thank you.
Thank you so much, ma'am.
All the best for
I had
the
actually
session.
forgotten in aneuploidy screening that I'm contesting.
We would like to conclude our session by saying thanks to everyone who has helped in the online platform. Shilpi Chaudhary, Mr. Abhijit, Mr. Dinesh, and all speakers, faculties, and eminent special chief guest and guest of honor. Everyone I would like to thank for this contribution and making it so successful webinar. Thank you so much.
Thank you. All the best, Dr. Bela. All the best.
For making me part of it and making it so successful. Thank you so much. Thank you.
Thank you, ma'am, and all the best.
Thank you. Thank you.
Smita, we can end, Shilpa, we can end the session now.
Yeah.
Okay, ma'am.